Okay. Hello, everybody. My name is Sidrah Fathima, and I will be the PAL tutor for the lower limb anatomy uh, practice session. So this session will be really interactive. So I'd like if you guys could please answer the questions. You could write it in the chat. You could unmute yourself. That would be anything would be fine. Just try to keep up with the session and try to answer questions. And inshallah, it will be a really helpful session because I tried to include as many high yield topics that might show up in your exam. So let's get started. Okay, so the first lecture is bones and joints of the pelvic girdle. So here's the first question. So a 71-year-old grandmother falls halfway down the basement stairs while carrying a laundry basket. She does not lose consciousness, but sits at the bottom of the stairs, gathering her wits and the scattered laundry. She does not think she fractured any bones, so she can move all her limbs. As she can move all her limbs, her husband, who hears the noise, helps her stand up. It is then that she feels a slight pain in her left hip on weight bearing. She limps for the rest of the day. The next morning, her husband brings her into their family physician's office, where it is noted that she walks with her pelvis tilted as if her left leg is slightly shorter than the right. She still has left hip pain. A plain film is ordered of the left femur from hip to the knee, expecting to find which of the following. So A, femoral neck fracture with compression, B, femoral neck fracture with complete displacement, C, a spiral fracture of the femoral shaft, D, a transverse supracondylar fracture, or E, an intercondylar fracture. What do you guys think is the answer? A. Does anyone have any other choices or answers? Okay, so you're correct. It is A. And it is A. And the reason why it's A is because she feels a slight pain when she puts weight on her left hip. And also she walks with her pelvis that's tilted and her left leg is slightly shorter than the right. An important thing to mention is that she's 71 years old and she's a female. So this is important because most patients that are 71 years old, they have osteoporosis and they often have femoral fractures. And so that shows you that it's a neck fracture with compression. Moving on. Okay, so here's a table of all the different fractures of the lecture, and I want to draw your attention to certain fractures. So first of all, there's the avulsion fracture, which usually happens when there's a sudden muscle contraction. So usually in the clinical scenario or any question that you're given, it'll say a patient was sprinting or they're kicking, and then suddenly they have a pain and swelling in their hip region. So this is an avulsion fracture. Now, there's also these two really important femoral neck fractures that you need to know. The first one is a transcervical fracture. And the most important thing about this is that it disrupts the blood supply of the retinacular arteries, whereas the other one, which is the intertrochanteric fracture, is between the lesser and greater trochanter, but the blood supply is not affected. So here in this picture, you can see that the transcervical fracture is in the middle of the neck, and the intertrochanteric fracture is between the two trochanters. So when it's here, it affects this retinacular arteries, which affects the blood supply. But when it's in the intertrochanteric area, it does not affect the blood supply. Now, another thing to know is something called avascular necrosis. So sometimes when there's a femoral neck fracture, it can disrupt the medial circumflex femoral artery, which can lead to avascular necrosis, which is basically the blood supply of the head of the femur gets compromised, and then the bone and all the connected tissue around this area starts to die out. Okay, moving on, there's also different types of fractures like the midshaft fracture, supracondylar fracture, and the patellar fracture. I want to draw your attention to the midshaft fracture, specifically because it's in the diaphysis of the femur. And this can cause severe pain, but also can lead to something called fat emboli. Now, fat emboli is not always seen in a midshaft fracture, but it can be caused due to a midshaft fracture. And this is because the bone marrow in the diaphysis of the femur has fat in it. And so when the femur has a fracture, this fat escapes and goes into the blood vessels of your body, obviously, and it lodges into organs such as the lungs, the brain, and even the skin. And it can lead to like stroke in your brain, or it can lead to pulmonary emboli somewhere else. And so this is a very severe complication of a midshaft fracture. There's also the supracondylar fracture and the patellar fracture, which is usually when someone falls on a flexed knee and they have an inability to extend the knee. Okay, moving on to question 2. So we have two 11-year-old boys sneak up on their friend from behind. In surprising their friend, they shove him suddenly, which forcefully pushes his hips forward while he is standing relaxed, talking to other friends. Which of the following ligaments best resists anterior dislocation of the head of the femur? A, the iliofemoral ligament, B, the pubofemoral ligament, C, ischiofemoral ligament, D, lacunar ligament, or E, ligament of the head of the femur. Which one do you guys think it is?
Is it B?
B. Um, no, not quite. Does anybody else have any? Okay.
A.
Yes, you're correct. It is A. It is the iliofemoral ligament. Now, I understand why you think it's the pubofemoral ligament, because in the anterior portion, there's two ligaments, right? There's the iliofemoral and there's the pubofemoral. But the reason why it's iliofemoral and not pubofemoral is because when you look at this question, it says, which of the following ligaments best resists anterior dislocation? And the iliofemoral ligament is the one that's the strongest. So it's the one that works the hardest and it's the best ligament to resist anterior dislocation. So yes, so in the anterior portion, there's the iliofemoral ligament and the pubofemoral ligament. And just to tell the difference between these muscles, if you ever see it in the OSPE or in an MCQ, just know that the iliofemoral ligament looks like an upside down V, while the pubofemoral ligament is just underneath this upside down V. Now, in the posterior segment, we have the ischiofemoral ligament, which is the only ligament of that area. Now, something related to this area is this clinical condition here on the side. Do you guys see it? These two conditions. Could anyone tell me what this condition is over here? Yes, it is coxivarus. And do you know what the angle is exactly? Yes, exactly. So coxavera is when the angle is less than 120. The angle of inclination is less than 120. And this is usually seen with people who have a fracture of the femoral neck. And usually they present with a shortening of the limb, and that limits the passive abduction of the hip. Now, in this case, it is. If this isn't coxavera, then it's, yes, exactly. It's coxavalga. And the angle here is greater than 140. So as you can see here, it's like a very big angle. And this is usually seen in congenital deformities or congenital hip dislocation. And it's important to know that the normal angle of any hip inclination is between 120 and 140 degrees. Okay, moving on to the next lecture, which is the gluteal muscles and the neurovascular bundle. Okay, so a 37-year-old woman has been suffering for months from piriformis entrapment syndrome, which was not relieved by physical therapy. Part of the sciatic nerve passed through the piriformis, and a decision was made for a surgical resection of the muscle. When the area of entrapment was identified and cleared, a tendon could be seen emerging through the lesser sciatic foramen, at first hidden by two smaller muscles and several nerves and vessels destined for the region of the perineum. The tendons of which of the following muscle pass through this opening? A, obturator internus, B, obturator externus, C, femoris, D, gluteus minimus, and E, gluteus medius. Yes, you're correct. It is obturatus internus. But before I get into the foramens and so on and so forth, does anybody know what the piriformis entrapment syndrome is? Yes, exactly. So as you see in this diagram, so this is the piriformis muscle, and this is the sciatic nerve. Exactly, and this is the bone. So if the piriformis hypertrophies for any reason, and it bulks up or like there's swelling in this muscle, and it compresses on the sciatic nerve, it leads to the piriformis entrapment syndrome, which means that any of the dermatomes that are supplied by the sciatic nerve, any of the muscles that are supplied by the sciatic nerve, doesn't work, or you don't have any sensation in those areas. So moving on to the different canals. And I know this is a lot, but it's not that bad, hopefully. So we were talking about the lesser sciatic foramen, but let's start with the obturator canal. So this obturator canal, which is here, it's very easy. There's just two things that you need to know: the obturator nerve and the obturator vessels. And the obturator vessels, of course, are the artery and vein. So it's easy to remember that. Now for the greater sciatic foramen, there's something above. So it's above the piriformis muscle, and there's stuff that are below the piriformis muscle. So anything that is above the piriformis muscle, you can call it nav, basically. The superior gluteal nerve, the artery, and vein. For the ones that are below the piriformis muscle, you could use a mnemonic or an acronym called SIP-PINK. And so the S stands for the sciatic nerve, the I stands for the inferior gluteal nerve, the P is the pudendal nerve, the I is the internal pudendal artery and vein, the N is the nerve to the obturator internus, and the Q is the nerve to the quadratus femoris. And then for the lesser sciatic foramen, you could use a acronym called PINTO, which is the P is for the pudendal nerve, the IN is for the internal pudendal vessels, and the TO is basically the obturator internus muscle tendon. So hopefully that helps. I mean, I know it's really difficult to memorize all these things, but hopefully these mnemonics will make things easier. Okay, moving on to question 4. A 62-year-old woman slips and falls on the bathroom floor. As a result, she has posterior dislocation of the hip joint and a fracture of the neck of the femur. The woman experiences weakness when abducting and medially rotating the thigh after this accident. Which of the following muscles is most likely damaged? It's not maximus.
Is it E?
Yes, it is E. It's gluteus minimus. So gluteus minimus is one of the muscles that is involved with abducting and medially rotating the thigh, but there's also another muscle that's involved, which is the gluteus medius. Okay, so here is just a table from, I think, your lecture with the different types of muscles. And I'm just going to, just going to ask you about the nerve and the action, just like tell me what it is. It's going to be like an Anki style. So do you know what, for gluteus maximus, what the nerve is?
Inferior gluteal?
Yes, it is the inferior gluteal. And do you know what the action is?
A flexion of the hip joint.
Mm, no, it extends and rotates the thigh laterally. Okay. And then for the superior gluteal nerve, which abducts and rotates the thigh medially, what other muscle does that except for the gluteus minimus?
The gluteus medius.
Yes. Okay, now for the tensor fasciae lata, what is the nerve? It's kind of similar to this. Okay, so the nerve is the superior gluteal nerve. So the gluteus medius, gluteus minimus, and tensor fasciae lata are all innervated by the superior gluteal nerve. Then the piriformis, what is the function of the piriformis? It's very similar to the superior gemellus, inferior gemellus.
External rotation of the
No.
thigh.
Oh yeah, actually, yeah, external rotation. It's lateral rotation as well. Okay, and then for something that abducts and rotates the thigh laterally, what muscle would that be? Hint, its tendon also goes through the lesser sciatic foramen.
Serrator internus.
Yes, obturator internus. And lastly, there is a nerve that's innervated by the nerve to the quadratus femoris, and it rotates the thigh laterally. It's a quadratus femoris. So yeah, this was just, I guess, for fun. It's like an Anki type. So you could use this to learn and to do active recall for the muscles. And it's really important because these muscles are very important to know the nerves and the actions because a lot of questions will be asking about those. Okay. So moving on to the next lecture, which is the muscles and the neurovascular structures around the thigh. Okay. Question 5. A 49-year-old male construction worker is admitted to the emergency department with a painful lump on the proximal medial aspect of his thigh. Radiological and physical examinations reveal that the patient has a herniation of abdominal viscera beneath the inguinal ligament into the thigh. Through which of the following openings will a hernia of this type initially pass to extend from the abdomen into the thigh? A. Femoral ring. B. Superficial inguinal ring. D. Deep inguinal ring. C. Deep inguinal ring. D. Fossa ovalis, and E. Obturator canal. Yes, it is the femoral ring. So the key thing is it goes through the inguinal ligament, and here is just something, here is something that just shows. So we have the inguinal ligament. In the inguinal ligament, we have this compartment, which has the femoral nerve, the femoral sheath, and within that is the femoral ring, where a lot of hernias go into. So another important thing is understanding this femoral triangle. So these boundaries of the femoral triangle and the contents of the femoral triangle are very, very important. You'll see a lot of questions which will just ask about the medial side, the lateral side, so you need to know. So first of all, what is the medial part of the femoral triangle? It is the adductor longus. The lateral part is the sartorius, and then the base is the inguinal ligament, which is here. Now the floor is divided into lateral sides and medial sides. So if you look over here, the lateral side is the iliacus and psoas muscles, which you can also call the iliopsoas muscles, and the medial side is the pectineus muscle. And then the roof of all of it is the fascia lata and the skin. Now this is important because I saw a question in one of the finals where it asked about the floor muscles, the lateral part and the medial part. So make sure you know that, and make sure to know which one's lateral and which one's medial. And here is a mnemonic for the contents of the femoral triangle. You can just follow it as navel. I'm pretty sure they taught this in the anatomy lab where N is the nerve, A is the artery, V is the vein, then E is empty space, and L is for lymphatics. And it's relatively simple. Okay, moving on to question 6. So a thoracic surgeon is going to collect a portion of the great saphenous vein for coronary bypass surgery. He has observed that this vein runs A, posterior to the medial malleolus, B, into the popliteal vein, C, anterior to the medial condyles of the tibia and femur, D, superficial to the fascia lata of the thigh, and E, along with the femoral artery. Yes, it is D. Oh gosh, superficial to the fascia lata of the thigh. And so here this is a horrible picture, but basically here's the femoral artery. As it runs through this opening, there's a great saphenous vein which goes above or anterior to the fascia lata and the skin, or below the skin. Another thing that's really important is the femoral artery, and this is important when it comes to cardiac catheterization. So the femoral artery comes from a branch of the external iliac artery, and this external iliac artery then joins with the common iliac artery, which then becomes the abdominal aorta. So when they want to do cardiac catheterization, they'll go through the femoral artery into the external iliac artery, and then into the common iliac artery to the abdominal aorta, and then eventually to the left ventricle. So that's an important, I guess, clinical correlation to remember. Okay, moving on. So a 52-year-old woman slipped and fell and now complains of being unable to extend her leg at the knee joint. Which of the following muscles was paralyzed as a result of this accident? A, semitendinosus, B, sartorius, C, gracilis, D, quadriceps femoris, and E, biceps femoris. Yes, you're correct. It is the quadriceps femoris. So the main key thing here is extending her leg at the knee joint, and that's usually the function of the quadriceps femoris. Okay. So can anyone tell me what this muscle over here is?
Iliacus.
Yes, the iliacus. What muscle is this? This one that goes here.
Is it the sartorius?
Yes, it is the sartorius. What is this muscle over here, this big one?
Rectus femoris.
Exactly. And this muscle over here?
One of the vastus. I think medialis, maybe?
Yes,
Media.
here's vastus medialis. And this muscle over here? If this is
Vastus
medialis,
lateralis.
exactly, it's vastus lateralis. And then below this would be the vastus intermedius. And then this thing over here is,
The tendon.
yes, the quadriceps tendon. Okay, can you tell me what is the nerve for all of these muscles?
The femoral.
Yes, the femoral nerve. That's great. Moving on to the posterior compartment. Could you tell me what this muscle here is?
Pectineus.
Yes, pectineus. What is this muscle here?
Adductor brevis.
Yes. What is
And
this muscle?
maximus.
Longus. It's abductor longus. This muscle?
Adductor maximus, I think, or magnus.
Yes, abductor magnus. Adductor magnus, my bad. And what do you think the nerve is for this, for all of these muscles?
Obturator.
Yes, the obturator nerve. There are some like sciatic and femoral, but mostly it's obturator nerve. And most of their function is just adducting based on the name. Then onto the posterior compartment. What is this muscle?
Semitendinosus.
It is the semitendinosus. And this one over here?
Membranosus.
Yes, this one?
Bicep.
Okay, but which one?
The bicep femoris.
Yes, but which one though? There's two.
Or which head?
The
Yes.
long one.
Yes, and this one would be the short one. Okay, what do you think is the nerve?
Is it the tibial?
Yes, the tibial of what though? Is it tibial nerve? Or like, is it part of something?
Yeah, the tibial nerve, I think.
The tibial nerve portion of the sciatic nerve. So, yeah. And then they all have the same action, which is extending the thigh, flexing, and rotating the leg medially. So that's great. Okay. We've gotten past that. Now we're on to the knee joint. Okay, so While playing football, a 19-year-old college student receives a twisting injury to his knee when being tackled from the lateral side. Which of the following conditions most likely has occurred? A, tear of the medial meniscus, B, ruptured fibular collateral ligament, C, tenderness on pressure along the fibular collateral ligament, D, injury of the posterior cruciate ligament, or E, swelling on the back of the knee joint. Okay, you said A. Okay, that's correct. But what exactly is this condition talking about? The key thing is that they're tackled to the lateral side. And if they have a tear of the medial meniscus, what could possibly also be affected?
The MCL and the ACL as well.
Yes. And this whole thing is called, there's like a name for it.
Unhappy triad.
Yes, the unhappy triad. So this is very important. I'm pretty sure you'll get a question about this. So basically, an unhappy triad is when you have an injury to the lateral side, and because of that, this medial collateral ligament, also known as the tibia collateral ligament, something like that, gets affected and it gets torn. And because this medial collateral ligament is attached to the medial meniscus, it also gets torn. And then also the anterior cruciate ligament gets ruptured as well. So all three of these get affected, which causes the unhappy triad syndrome. So just to explain these different ligaments of the knee, which is very high yield, and you'll probably get multiple questions, at least of this. So there's a couple of ligaments. So we already know there's the menisci, which is there's the medial, the lateral menisci. And then there's also the cruciate ligaments. So there's the anterior cruciate and the posterior cruciate. So the anterior cruciate ligament basically prevents anterior displacement of the tibia. So if you're to push on this tibia from the back to push it forward, this anterior cruciate ligament should prevent that from happening. Similarly, the posterior cruciate ligament should prevent posterior displacement. So if you're to push the tibia backwards, it should prevent that from going too far back. And this is important when we talk about the two different tests. There's the anterior jar test and the posterior jar test. So with the anterior jar test, you basically pull on the, I'll show you, I don't know if I can draw, but you pull on this anteriorly, pull on the tibia anteriorly, and you should feel resistance. If there's no resistance and that tibia goes forward, that means there's probably a damage to this anterior cruciate ligament. For the posterior drawer test, what you want to do is you want to push on the tibia backwards, and you should feel resistance. If not, and it goes more posterior than usual, then that means there's something wrong with the posterior cruciate ligament. Also, what you can see here is the tibial collateral ligament, also the medial collateral ligament, which is attached to the medial meniscus, and here the fibular collateral ligament, which is also known as the lateral collateral ligament. So these are the main ligaments that are very important. Okay, how do I get rid of this? No, no, it's all showing. It's ridiculous. Okay, I figured it out. Okay, pretend you didn't see that. So for question 9, a 35-year-old carpet installer presents with swelling and tenderness over the front of his right knee. He reports that his symptoms started after prolonged kneeling during work. On examination, there is a localized soft fluctuant swelling just anterior to the patella with overlying skin redness but no signs of systemic infection. Which of the following is the most likely diagnosis? Yes, it's A. So prepatellar bursitis. And this is also known as, of course you didn't see, you just knew it. So, okay, but here's the question. What is this also known as? Prepatellar bursitis. Like what's like the famous name for it, for this condition? Okay, So the name of it is also called a housemaid's knee. And basically it's because like housemaids, I don't know, back then used to like go on their knees and like scrub on the floors, and the friction was what would cause prepatellar bursitis. And so that's basically what it is. It's the friction of this bursa against the patella, which causes this swelling in anterior to the patella. Now there's another condition which is called clergyman's knee, which hold up. Okay, clergyman's knee, which is associated with the subcutaneous infrapatellar bursa. Now, they're very similar because both of them involve people that are kneeling on the floor, but the way you can tell the difference is the location of the swelling. So for a subcutaneous prepatellar bursa, it's anterior to the knee, right? So you would have swelling anterior to the knee. But if it was clergyman's knee, it would be below the kneecap or just below this area. There's also something else called the Baker cyst, which is a cyst in the semimembranous bursa or in the popliteal fossa, this bursa over here. So those are three clinical conditions that might be associated with bursas. Okay, moving on to question 10. When standing upright, the femur moves into the locked position by slightly hyperextending, gliding posteriorly, and medially rotating on the tibial plateaus. Which of the following muscles acts to initiate the unlocking of the knee? A. Biceps femoris, B. Gastrocnemius, C. Popliteus, D. sartorius, and E. plantaris. Yes, it's true. It's popliteus. So for the locking mechanism of the knee, it's basically medial rotation of the femur is what locks the knee, and to unlock it, it's a lateral rotation of the popliteal muscle. Okay, great. We're moving on to the popliteal fossa. So question 11, when the femur is fractured, the broken distal end often turns posteriorly to enter the popliteal fossa due to muscle traction. Because of its position deepest in the fossa, which structure is most vulnerable to laceration? A, the common fibular nerve, B, lesser saphenous vein, C, popliteal artery, D, popliteal vein, or E, tibial nerve. Not quite. It's not the tibial nerve.
Is it C?
Yes, it's the popliteal artery, C. Okay, so let me show you. This is the popliteal fossa. And so a good way to remember what's deep and superficial is this mnemonic, which is a very furious traveler. So A is popliteal artery, which is the deepest. Then V is the popliteal vein, which is anterior to that. Then F, which is the common fibular nerve, and T is the tibial nerve. So that's the best way to remember it. Okay. Question 12. A 27-year-old man has had increasing difficulty walking and complained of an area of numbness on the dorsum of his right foot. Examination reveals a hard mass at the anterolateral aspect of his right leg, just below the knee. Imaging studies reveal a large bone tumor between the fibula and tibia that is compressing a nerve, accounting for his neurological symptoms. Which of the following is the most likely description of abnormalities on neurological examination? So A, decreased or absent knee jerk reflex and decreased sensation on the medial aspect of the leg. B, weakness of flexion at the knee and decreased sensation of the plantar aspect of the foot. C, weakness of eversion at the ankle and decreased sensation between the first and second toes. D, weakness of inversion, dorsiflexion at the ankle, and decreased sensation between the first and second toes. E, weakness of plantar flexion at the ankle, weakness of toe flexion, decreased sensation of the plantar aspect of the foot. Okay, so this one's a little tough because there's just too much going on. But hopefully you understand, like you get which nerve. First of all, which nerve is affected, do you think?
Is it common fibular?
Yes, it is the common fibular nerve. And so if the common fibular nerve is affected, what do you think would be, what muscle or what movement would be affected? Sensation maybe.
I think the sensation of the most of the dorsum of the foot would be lost.
Yes, that is true. The sensation of most of the dorsum of the foot would be lost. So that is the answer. So yeah, it's weakness of inversion, dorsiflexion of the ankle, and decreased sensation between the first and second toes. Wait. Okay. So basically here is the common and peroneal nerve, which is affected. And so imagine there's a tumor here, and it's basically goes downwards and affects, it's mostly on the dorsal part of the leg. That's okay. So here you can see the supply of this nerve, and you can see it's affected over here. Okay, now I'm just going to quickly go over the anterior compartment of the leg. So there's different muscles for each, but the good thing is they're all supplied by the same nerve for each different compartment. So for example, in the anterior compartment of the leg, they're all supplied by the deep fibular nerve. And there's three different muscles, the tibialis anterior, which is here, extensor hallucis longus here, and extensor digitorum longus. These both, because it has extensors, they extend the foot, and they all dorsiflex the foot. The only thing that's uncommon is that this one everts the foot while these ones invert the foot. And here are just pictures of what inversion looks like and eversion looks like, and dorsiflexion and plantar flexion. Then we get into the lateral compartment of the thigh. There are two muscles and one nerve, which is the superior superficial fibular nerve. And there is the fibularis longus, which is here, and the fibularis brevis. And they both have the same function, which is eversion of the foot and plantar flexion. Then we have the posterior compartment of the leg. So the nerve here is a tibial nerve, and there is the plantaris, which is here. The heads of the gastrocnemius is here, soleus, and then this calcaneal tendon, which is involved in the Achilles tendon reflex test. So if you see a question that says they're hitting this tendon to check for a reflex, or they're hitting the Achilles tendon to check for a reflex, it's always the tibial nerve that they're checking for. And then here are the deeper part muscles, the popliteus, the tibialis posterior, flexor hallucis longus, and flexor digitorum longus. Okay, moving on. So a 25-year-old man suffers a gunshot wound to the calf that severs the posterior tibial artery at its origin. Which of the following vessels will not receive blood flow immediately following the injury? A, anterior tibial artery, B, inferior medial genicular artery, C, dorsalis pedis artery, D, popliteal artery, or E, fibular or peroneal artery.
Is it B?
B? No, it's not B. Okay, so the answer is E, the fibular or peroneal artery. And so if you see it from here, you can see that the posterior tibial artery gives two branches, the circumflex branch and the fibular artery. So if it was severed, that means that the fibular artery would also be compromised. Okay, moving on. During orthopedic surgery involving ligation of the femoral artery just above the abductor hiatus, the surgeon relies on collateral circulation to maintain blood flow to the leg. Which of the following arteries helps maintain perfusion to the knee joint by participating in the genicular anastomosis?
Is it B?
Did you say B?
Yes.
Yes, it is B. It's the superior lateral genicular artery. So here's the anastomosis, okay? and it's a lot. So I have a mnemonic for you, which is some doctors prefer injecting anesthetic medicine daily. And I guess it just helps to identify the main type of arteries that are involved. Like S is the superior medial genicular, D is this descending genicular, B is posterior tibial recurrent, I inferior medial genicular, A anterior tibial recurrent, M middle genicular, and D descending branch of lateral circumflex femoral. You could try drawing this out to like try to memorize it, but really it's just the medial genicular type of arteries that might be asked about. And hopefully this mnemonic can help you remember them if you ever see it in an MCQ. Okay, now we get into the ankle joint and the bones of the foot. Okay, we're almost done, hopefully. So question 15. A 32-year-old male basketball player comes down hard on his ankle. He is admitted to the outpatient clinic and radiological examination reveals a POTS fracture. What ligament is most likely injured? A, the calcaneofibular ligament, B, the deltoid ligament, C, spring ligament, D, plantar ligament, or E, long plantar ligament?
B.
B, yes, the deltoid ligament. Okay, so let me go to here. Okay, so we will talk about this part first. This is a POTS fracture. So the deltoid ligament is here. And in a POTS fracture, what you usually see is rather than this ligament being like torn or anything, you'd most likely see that the malleoli are affected on both sides. And that's because this deltoid ligament is very strong. So a POTS fracture is seen with a fracture of the medial malleolus and the lateral malleolus. And here is an inversion injury where this type of injury is more common, and usually it's when you have the inversion of the foot and it ruptures 3 types of ligaments, depending on the severity, of course. So we have 3 ligaments involved, which is the posterior talofibular, the anterior talofibular, and the calcaneofibular. And usually, whenever you have this lateral ligament injury, the anterior talofibular is mostly torn because it's the weakest out of all of them. Okay. Okay. Oh my gosh. Okay. Well, pretend you didn't see that, but basically, a 12-year-old boy is brought to the ER by his mother after being pushed out of the neighbor's tree house about 10 feet off the ground. He can walk, but his right heel hurts every time he puts weight on it. When his foot is examined, it is found to be tender to pressure on both the medial and lateral aspects of the heel inferior to the tibia. Plain films of his right lower extremity are ordered because of suspicion that he has fractured which of the following? And like you can see, the answer is calcaneus. The question is, why is it calcaneus and not, cuneiform and navicular? Okay, well, I'll tell you. It's calcaneus because calcaneus is the most common fracture of like the foot. That's the main reason. So if you were to have a MCQ about a fracture of the foot, most likely it's the calcaneus that's fractured. Okay, so here is actual questions. What condition do you see here?
A bunion.
Yes, a bunion, but before it becomes a bunion, like bunion is the pain, what exactly is happening?
The toe is laterally rotated.
Yes, but there is a name for it. It's very similar to in the hip with the inclination.
This is something, I think, valgus.
Yes, it's hallux valgus. Hallux because it's the big toe, and valgus because it's like that. So yeah, and it can cause a bunion if it gets irritated and it becomes more pronounced and painful, and then it can also cause have to be surgically removed and so on. Now, this condition, what exactly is it? hint this thing over here. And this bone, which is here. No. What is this bone?
It's the overgrowth of the calcaneus bone.
Yes, it's called a calcaneal spur, which can lead to plantar fasciitis because this will just press on the fasciitis and then cause inflammation over time. So yeah, these are two clinical features that you most probably will see in like this. So yeah. Okay, moving on to the arches of the foot. Okay, so a veteran, this one too, this is ridiculous. Wait, is it? Okay, I'm sorry about that. But a veteran infantry soldier develops painful flat feet after several years of service, including hundreds of miles of marches. The pain is particularly acute on the medial aspect of his sole. Which of the following structures is most likely strained in this condition? You can see that the answer is plantar calcaneonavicular ligament. But I'll ask you a few extra questions. So first of all, what arch of the foot is involved in this? Usually with flat feet.
The medial arch.
The medial arch, yes. And this spring ligament, is it a dynamic support or a passive support?
Passive.
Yes. Do you know what another passive support is?
The other ligaments.
Mm, not exactly. It's called the plantar aponeurosis. That's the other passive support. But you're close though. So for the medial arch, there's a dynamic support, and then there's the passive support. So the dynamic support is these three muscles, so the flexor hallucis longus, tibialis anterior, and tibialis posterior. Okay, and the passive support, like you said, is the spring ligament and also the plantar aponeurosis. And this is really important. You might get questions on this. So yeah, so moving on to this one. A 42-year-old hiker presents with lateral foot pain after a long trek. Examination reveals flattening of the lateral side of the foot. The lateral longitudinal arch of the foot is supported by several structures. Which of the following provides passive support of the lateral longitudinal arch? It's passive support. Okay, so if you don't have an answer, I'll tell you. It is the long plantar ligament. Okay, I'm just going to show you this. So as a rule of thumb, basically, the passive support of either the medial arch or the lateral arch is usually a ligament. So in the lateral arch, it's the long plantar ligament, the short plantar ligament, and the plantar aponeurosis. Whereas in the medial arch, it was this it was the spring ligament and the plantar aponeurosis. When it comes to dynamic support, it's usually muscles like the fibularis longus or intrinsic plantar muscles. And it makes sense, right? Because the muscles are dynamic, they move, right? Whereas passive things are ligaments. They just resist movement. Do you understand?
Yes.
All right. Okay, moving on. Okay, second to last, clinical anatomy of the lower limb. Okay. So a 55-year-old woman presents with varicose veins and chronic leg swelling. Her symptoms worsen after long periods of standing and improving with walking or elevating her legs. Which of the following best explains the improvement in symptoms with walking? So A, increased lymphatic drainage from superficial tissues. B, enhanced arterial supply to superficial veins. C, activation of the plantar venous pump and calf muscle pump. D, decreased venous pressure due to arterial vasoconstriction. And E, relaxation of the deep fascia, allowing venous expansion. And yes, you're correct. It is C, the activation of the plantar venous pump and calf muscle pump. So yeah, it's basically like this. So when the calf muscles are relaxed, right, the valves are closed and blood doesn't really flow in the veins. But when we have contraction of these muscles, we have the valve opening and blood is able to go upwards to the heart. Now, usually if you spend long periods of just standing or sitting down, for example, long flights, you'd develop varicose veins because you don't have this calf muscle pumping these veins and pumping the blood to the heart. And yeah, so that's the condition. And just remember, varicose veins is involved with this calf muscles and the veins. Okay, moving on to the next question. A 30-year-old man is brought to the emergency department after a motorcycle accident. He was thrown off the bike and he is unable to move the hip due to severe pain. Imaging confirms a hip dislocation. Which of the following findings is most consistent with an anterior dislocation of the hip?
Is C?
Yes, it is C. The limb held in abduction and external rotation. Now, let me just compare the two. So we have anterior hip dislocation and posterior hip dislocation. First of all, anterior hip dislocations are mostly rare, whereas posterior hip dislocations are much more common. And the typical presentation for an anterior hip dislocation is that the limb is externally rotated, it's abducted, and the limb is lengthened. Whereas in a posterior hip dislocation, it's usually flexed, adducted, and internally rotated, and the limb is shortened. Also, it usually occurs with a dashboard injury. So a dashboard injury is when, like in a car, when the knee hits the dashboard and the femur goes backwards, and this causes the hip dislocation. What you also know is an anterior hip dislocation. It usually has a risk of injury to the femoral nerve or artery, whereas in the posterior hip dislocation, it's with the sciatic nerve. And also in the posterior hip dislocation, it can involve a fracture of the posterior acetabulum. Okay, that's that. Lastly, the lower limb nerve injuries. Okay, so during a patellar tendon reflex test, you note appropriate extension of the knee joint. You conclude the integrity of which nervous structures are intact. Okay, yes, it is A, the L2, L4 femoral nerve. Okay, and so this is from this the lumbar plexus, and you have different like divisions of it. And a good mnemonic of this is this one, which is I twice get lunch on Fridays, luckily. So I twice means I two, like two eyes. So iliohypogastric, ilioinguinal, G is genitofemoral, L lateral femoral cutaneous, O is obturator, F is femoral, and L is lumbosacral. And this is very important because you probably will get a lot of questions just asking about the different branches and which they come from. So make sure to understand this and use this mnemonic to guide you through it. Okay, last question. A 23-year-old man is admitted to the emergency department with a deep bleeding stab wound of the pelvis. After the bleeding, he has been arrested. An MRI examination gives evidence that the right ventral primary ramus of L4 has been transected. Which of the following problems will most likely be seen during physical examination? A, reduction or loss of sensation from the medial aspect of the leg. B, loss of the Achilles tendon reflex. C, weakness of abduction of the thigh at the hip joint. D, inability to evert the foot. And E, reduction or loss of sensation from the medial aspect of the leg and loss of Achilles tendon reflex. Okay, not E, but you're close. They're very similar. It's yes, the answer is A. It's the reduction or loss of sensation from the medial aspect of the leg. So the reason why it's not E is because, hold on, let me see. I need to go back because I can't really see it. Oh, oops. Yeah, so like for the L4, usually we're talking about dermatomes here. So it affect the medial part of the thigh. in sensation, but not necessarily the movement, which, oh my gosh, I keep doing this. Not exactly the loss of the Achilles tendon reflex, right? Because it is by the tibial nerve. Okay, so yeah, that basically concludes our session for the lower limb. And I hope you guys enjoyed it and I hope it was helpful. Just a few bits of advice before I finish is just that try to do as many practice questions as you can for these anatomy, like the muscles, the innervation, the blood supply, because you'll see a lot of them in like different formats. Like you'll see maybe like a nerve being injured and they'll ask you about the movement, or they'll just give you like an image and they'll ask you about the muscle and they'll say, what muscle is this? What is the innervation? And what is the blood supply? So make sure to do a lot because that will help you. And yeah, other than that, I think you guys are very good. You answered, sorry, you answered really well, and that's pretty amazing. So that's it for my part. Do you guys have any questions for me? You're welcome. Thank you very much. And I hope it was really helpful. So I'm gonna stop sharing.
Okay, hello everyone. My name is Feham. I'm a 5th-year student, and today I'm going to be going over the practice questions for the upper limb. So that I covered lower limb, I'll be doing upper limb. And I'm covering roughly like 30 questions, but it should cover really all your 13 lectures, or I think 12 lectures that you have for the upper limb, okay? We're just going to be going over each shoulder region. And what I try to cover is I went through all your transcriptions to make sure that you know the things that the doctors emphasized on is going to be covered. And I also went through your MSK booklet that the exam committee made and to see like, what are the common questions that you guys kind of get. And so those questions are also really going to be the high yield things that we're going to be covering, okay? And one of the things, I don't know if you guys got this as well recommended, but I was going through my pre-med notes in my, MSK because it was my first block back in first year. And back then what seniors recommended us to do was the University of Michigan practice questions. And those questions are basically just like each region, like shoulder, axilla, arm. They have like 10 to 15 questions in like a PowerPoint format. But those can be really helpful as well, just as a quick review. So I included some of those questions as well. And of course, it's anatomy. So a lot of it at the end boils down to really memorizing things. But I tried as much as I could to give you guys mnemonics or acronyms so that you guys can, remember it better. And also I used lots of comparison tables because yes, anatomy is memorizing, but you cannot memorize each fact on its own because what's the difference between doing this motion and doing this motion? You get me? Both looks the same, but it's completely different muscles and all have different nerves. And if you memorize each on their own, you might get confused when the options are coming after each other. So I tried to use lots of comparisons and comparison tables to really make that clear. Okay. If you guys have any questions at any point, just feel free to, bring it up. And yeah, also just want to give a quick shout out to Firas for letting me use his upper limb crash course slides. And also I went through some of the pre-med slides and I used those as well. But yeah, also some general advice just before we start for MSK in general, okay? There is so much information that they're going to give you guys, but you really need to know 3.5 things, okay? Number one, know all your ligaments because that's where the injuries happen. That's a lot of things that they're going to ask you about, so know them very well. Know your nerves because that's where all the clinical scenarios are going to come out of, right? Which muscle is innervated by that nerve is also very important. And obviously the muscle functions. But I would argue that even knowing more important than knowing the muscle functions, it's being able to recognize the loss of function. So if I say that the patient is unable to abduct, that means his arm is adducted, right? So sometimes it can become like a little bit of a English comprehension, more than, like anatomy exam. So make sure that you really know your muscle functions as well as the loss of functions very well. And the half thing that you need to know is kind of the arteries, okay? You don't need to know all the arteries about, the aortic trunk gives you three branches and those 3 branches give you another 3 branches. You don't need to know all these details. The main thing you need to know when it comes to arteries is the ones that are giving you anastomoses, okay? That's why I kind of included it as like a half thing because it's not as important except for when it comes to these anastomoses, okay? Veins, lymph nodes, low-key, just forget about them. They're very, very, very low yield, okay? Other advice would be, again, memorize them, yes, but also compare and contrast them so that you don't get lost. And during the exam, highlight the key clinical conditions, okay, in the scenario. So for example, difficult breech delivery, those keywords should ring something in your mind, okay, because they will bring you the classical examples. They will not try to complicate it for you, okay? And the last thing is act out the movements during the exam. What I mean by that is sometimes, as I said, it's like an English comprehension. Oh, he's able to extend his arm but he cannot flex his wrist and he cannot like, so do those movements in the exam, even if you feel like you're looking a little stupid, but it really helps you understand what is going on. Okay. Now, without further ado, let me just start with the first question. I'm gonna try to make this interactive. So if you guys want to unmute, you want to, answer in the chat, feel free. So yeah, just read the question on your own, and then whenever you have the answer, just let me know, and then I'll go over it. Any answer for this?
C,
C. Okay, why did you say C?
because they mentioned a positive painful arc and the abduction between 60 to 120 degrees.
Exactly, very good. So the idea here is it's a patient who is having worsening pain when she's reaching overhead. So this motion here is what is painful. And you can see already like you're using your shoulder region. So that's kind of giving you an indication of what's going on. She also recently started exercise. So that's giving you an indication she might be overusing it, okay? Because her muscles are not used to it, or her shoulder region. And the main thing is that her positive arc is there from abduction angle of 60 to 120. So abduction is this motion here. Okay, see, this is 90 degrees, the horizontal, so 60 is just below it. So she's having pain from here to roughly here. This motion here is what causes her pain, okay? When she actively moves it. However, her passive range of motion is normal. What's the difference between active and passive range of motion? Anyone can tell me?
Can I?
Yeah, go ahead.
So active is when you're doing it like yourself and you're using your muscle by yourself, and passive is when you're not like actively like using your muscle. So like for example, if you say like someone is moving it like for you and you're not actually doing the movement yourself.
Yes, very good. That's exactly true. So active is me doing it myself, and passive is if the doctor is lifting it for me. So that's very important. In this patient, she can move it on her own. That produces the pain. But when, it produces the pain when she moves it. But when someone else is just moving it, it's fine. Passive range is normal. She's able to move her arm fully. So this is what gives you subacromial bursitis as the answer. And let's briefly discuss this. Subacromial bursitis is also known as impingement syndrome, painful arc syndrome. It's really the same thing. Okay. So what's happening here basically is you can see, I can write it right. Okay, so you have your shoulder region here, and at your shoulder region, this is your clavicle, okay? And at the clavicle has, and then it attaches to the acromion here, which is part of the scapula, okay? So just below this acromion, there is a small bursa, which is like a fluid-filled kind of area that is just there for cushioning, okay? So you can see here that this is or here it's also in the same picture, subacromial bursa, and it's right below the acromion. So when you're moving your arm, as you can see in this patient here, she's moving from 60 to 120, you're kind of impinging on this acromion if you're overusing it and it becomes inflamed, okay? That's what impingement syndrome, subacromial tendonitis, it's all the same thing. The same subacromial bursa, when it kind of extends downwards, it becomes a subdeltoid bursa. But yeah, it's really the same thing. So what is important about this, knowing about impingement syndrome, is it's gradual onset, often because of overactivity, just like with our patient. She just recently started working out, and she's having painful active range of motion, but her passive is normal. So what does this contrast to? This contrasts with frozen shoulder. Can anyone tell me what frozen shoulder is? So frozen shoulder.
Can't move your shoulder.
Yes, okay. It is basically because of thickening and fibrosis of the joint capsule or the ligaments that are there in your shoulder region, okay? So what happens with that is both your active and your passive range of motion are restricted. So that means that she cannot move it on her own, and even when you try to move it, it's too stiff. That's why it's called frozen shoulder. Her shoulder is frozen. She cannot move it because all the fibrosis and all that is not allowing that. So that's the main difference that I want you guys to know between impingement syndrome and frozen shoulder. In one of the transcriptions, Dr. Atif was saying it's important to know, so like really know it. This is the main thing, okay? So yeah, that's that. Okay, let's go to the next question. So 17-year-old boy coming to the emergency room, he's having a hard fall on his shoulder. And on physical exam, you see that the distal end of the clavicle, so the further up, the further apart, is prominent, and you can feel it. Radiological findings are shown. Can anyone describe what the X-ray is, or what the X-ray is showing?
The tear in the ligament.
Sorry?
We could see that the clavicle is moving upwards. So
Yes,
the ligament
okay.
probably torn.
Very good. And which
That would
point
be
does that
B,
be?
Coracoclavicular ligament.
Yes, very good. So basically what you're seeing in this x-ray is normally your clavicle is supposed to be continuous with your acromion, okay? But what you're seeing here is that there is this separation between them and your clavicle is actually moving upward. So as you mentioned correctly, yes, the answer to that would be a torn coracoclavicular ligament. Let's briefly review that. So in the shoulder region, you have three main areas of joints, okay? You have your sternoclavicular joint, which is between the sternum and the clavicle. Main thing you need to know about this is that this is the only real joint that is connecting your axial skeletal system to your limbs, okay? A question that comes very often in the exam. That's what you need to know about this joint. The second joint is here, which is between the clavicle and the acromion, which is part of the scapula, the acromioclavicular joint. This acromioclavicular joint is stabilized by two ligaments, which are here in pink and in yellow. So there is the acromioclavicular ligament, which is a ligament right between that joint, obviously. But an important thing is that there is another ligament stabilizing the movement of the clavicle, which is the coracoclavicular ligament, the CC, okay? It's itself made of two things. You don't really need to know the names, just know like the main ligament, okay? And so what's important here is that this ligament here is attaching the clavicle to the coracoid process of the scapula. So what does that mean? If I, in this case, this is the clavicle, this is the acromion. So I have a ligament here. If this tears, it's still okay because I have my main coracoclavicular ligament that is still anchoring the clavicle downwards. If, however, I break this ligament, then that means now there is nothing holding my clavicle anymore, and that's what's going to give you the shoulder separation, okay? Your clavicle will move upward because that ligament is not holding it in place anymore, okay? And so this is what we call as shoulder separation. The third joint that is important here is glenohumeral joint, which is basically here between the glenoid fossa and your humeral head. This is your actual shoulder joint, and it's stabilized by the joint capsule, which has multiple ligaments. Okay, now a question though. What is the primary stabilizer of the shoulder joint though? Is it the ligaments or something else?
It's the rotator cuff muscles.
Exactly, very good. It's the rotator cuff muscles that are the main stabilizer of the shoulder joint. And one thing you need to know about the rotator cuff muscles is they cover the entire shoulder area except for the inferior portion. So that's why when you have a shoulder dislocation, not a shoulder separation is right here, this issue with the ligament. Shoulder dislocation is that the humeral head is moving inferiorly and anteriorly, most common, because there is no support at the base. Okay? Is that clear so far?
Yes.
All good? Okay, so again, the way I like to remember it is CC separates. So shoulder separation is because of the coracoclavicular ligament that is being torn. Okay, so this is what you can see here. This ligament is torn. This is what allows the clavicle to move upwards. And this is also what you see in the x-ray. Okay, can anyone describe the next x-ray for me? I'm going to be asking lots of questions like this. So yeah, please bear with me. What do you see is out of the norm in this x-ray?
Is it in a dislocation of the shoulder?
Yes, very good. So this, as you can see here, in shoulder separation, the humeral head is still within its fossa. It's just here that the clavicle is detached from the acromion. But here you can see, yes, clavicle and acromion are together, but the humeral head is actually out of its socket. So this is what is shoulder dislocation. It's very important to differentiate between these two, okay? And in shoulder dislocation, you can have anterior shoulder dislocation, which is the most common one. You can also have posterior ones, okay? What is this x-ray showing?
A fracture of the clavicle.
Yes, very good. You can see basically that the continuity of the clavicle is not there. It's broken here. And so which part of the clavicle is the most commonly fractured part?
The distal two-third.
Yes, very good. The middle kind of portion, the area between the middle two-third and the distal one. So that's very good. So you're going to have the clavicle fracture right here, usually because of trauma, you fall on it. And so you will see that also the clavicle is going to be pulled upward because of the sternocleidomastoid muscle. Okay. Yeah. Okay, so this is a brief table summarizing all of it. It looks like a lot at once, but we've already covered it. Shoulder separation, the main thing I want you guys to know, I'm going to give you guys the high yields, like everything you need to know, like, keywords. So I'm going to be focusing on certain things. Shoulder separation, what I need you to know, coracoclavicular ligament is damaged, okay? Shoulder dislocation, most common is anterior inferior. And clavicle fracture, typically the middle third, that's going to be broken. Okay. Now these pictures, they might look a little bit similar, but if you really think about it, it's not that, it is quite different. So step off, basically what you feel in shoulder separation is because we said that the continuity between the clavicle and acromion is not there, right? And the clavicle is pulled upward. So you will feel a palpable step off, just like with our patient, from the clavicle down to the acromion, but it's at the distal end. Whereas in a clavicle fracture, the fracture is usually in the middle, right? So you will feel a bump in the middle of the shoulder, not towards the end, okay? And in the shoulder dislocation, mostly what you find, you will look at the deltoid here, it's nice and rounded. The physical exam finding that you will find when the shoulder is dislocated because the shoulder is moving, you will find a flattened deltoid on the side of the dislocation, okay? Rest of it is, we've already kind of covered. Okay, next question. So we're having a 17-year-old boy, 3-month history of pain, right shoulder. He's having difficulty lifting his right arm. He doesn't have active abduction of his right forearm, of his right arm between 0 to 15 degrees. So just the initiation. But after he passively does it, then he's able to rise his arm over his head. So which muscle is most likely the dysfunctional muscle, and it's innervated by which nerve?
Is the supraspinatus?
Yes. And what is it
Is
innervated by?
the suprascapular A?
Yes, very good. So the main key things, active abduction is impaired, and after that, he's able to do it, okay? So how is that? Let's discuss shoulder abduction. What are the muscles that are involved in it? It's 3 main muscles: supraspinatus, deltoid, and serratus anterior. The way I like to remember it is teacher. You know, when you say teacher, you're trying to raise your hand. So teacher, I'm supra proud of my essay. Supra is just the initiation, okay? Supraspinatus. Proud is deltoid. I don't know if you guys can see it with the background, is like until 90 degrees deltoid. And then essay is serratus anterior moving upward. Okay. So teacher, you want to abduct. I'm supra proud of my essay. That's how I like to remember it. Which one comes first? Which one comes next? Okay. Someone has a question. I didn't understand the difference in the picture between shoulder separation and dislocation. Okay. Let me go back. So if you look at it, can I remove all the... discard. Let's try it. Okay. So this one here, my point was that if you look at it in shoulder separation, what did we see? The issue is that your clavicle and your acromion are not together anymore. They've separated from each other, right? So this separation, even in the x-ray, you can see, because there is this separation and this caracoclavicular ligament is gone, the clavicle moves upward. It's all intact. The entire clavicle is intact, but it just moves upward. So what you feel on physical exam is that there is a step off. You can feel that you're touching the clavicle and then suddenly it goes downwards and then you touch the acromion. Normally it should be smooth and continuous, right? So this is what we call the step off. The clavicle is intact until the end, and then you feel suddenly a drop going to the acromion. Whereas in the shoulder separation, so this is what this picture is showing you here. So this is the end. You can see that the clavicle is actually moving upward at the distal end. And there is a separation between the clavicle and the acromion, okay? Whereas in this picture, in the shoulder dislocation, the main thing what you see is this deltoid is flattened. You will feel that the clavicle and the acromion are still all continuous, but the deltoid is just going to be straight because your arm has moved inward. Is that clear? Does that make more sense? Here. Okay, great. Okay, so yeah, back to the shoulder abduction. So teacher, I'm super proud of my essay. That's how you can remember supraspinatus is there for the initiation of abduction. Then comes your deltoid, which is innervated by the axillary nerve, is there from 15 to 90 degrees. And afterwards is your serratus anterior. Serratus anterior is innervated by long thoracic nerve. This is very important to know. You can remember it as, salt mnemonic. And yeah, we'll have a question about it later on. Okay, is this clear so far? I'm assuming everything is clear. Okay, then let's go to the next question. Just kind of as a... So we're having a 54-year-old woman who's having a radical mastectomy for treatment of invasive breast cancer. Her pectoralis major muscle is removed because of tumor invasion. Which shoulder functions will most likely be impaired?
Medial rotation.
Okay, good. What else? Is that the only one?
Adduction too.
Yes. Okay. Very good. So it's both. Well, I should have asked you that, but okay. It's both A and B. It's both medial rotation and adduction that's impaired. So let's discuss the rotator cuff muscles and the muscles that come with it to answer this question. So you guys probably know the sits mnemonic that is there for the rotator cuff muscles. It's supraspinatus, infraspinatus, the teres minor, and the subscapularis, right? Instead of going through this, I'll just explain the shoulder movements and how you can remember them, okay? So the shoulder movements you have is external rotation, okay, or lateral rotation, which is this movement outwards. The muscles that are responsible for this are the infraspinatus and the teres minor. The way I like to remember it is exit muscle. EX is going to be for external rotation, I is for infraspinatus, and the small t is for teres minor. That's why it's written in small, okay? So external rotation is done by infraspinatus and teres minor. And then you have your internal rotation, the opposite, medial rotation, coming inward, okay? This is, this you can remember by slipped, okay? She slipped. So subscapularis is responsible for it. Latissimus dorsi, internal rotation is the I. Then pectoralis major and teres major. Both of them are major because I wrote P and T in capital, whereas here in exit, I wrote the T in small. So exit is teres minor. Slipped, the T here is for teres major, okay? So this is how you can remember the internal rotation. And in here, pectoralis major is part of internal rotation, as you said correctly in the question. We already discussed the shoulder movements of abduction. Teacher, I'm super proud of my essay. Now, adduction, unfortunately, I don't really have a good mnemonic for it. The only thing I realized it's really the same thing as slipped, or the only thing is subscapularis is not there for adduction. So if you just remove this and you keep the LPT, that's what's going to be there for adduction. I don't know if this is going to help you as much, but all you will see is that pectoralis major is also responsible for adduction. So yes, you are correct that both internal rotation and adduction are affected. Is that clear so far? Yeah, so
Yes.
that's what both A and B are clear. So it's part of slip mnemonic and also part of like, the adduction, which doesn't have a mnemonic, or just remember it as it's slipped, but without the S. Okay, so that's that. Okay, great. Next question. So we have a 52-year-old male. He's having difficulty fastening his seatbelt, and he reports history of heavy lifting at work. There is noticeable weakness when he attempts to rotate his arm inward. Which muscle and nerve combination is most likely responsible?
Is this C?
C, subscapularis and suprascapular nerve. Okay, what is the movement that they're talking about here?
They mentioned that it's inward rotation.
Yes. Very good. So basically what's happening here is that, when you're fastening your seatbelt is back there. So you're trying to get it and do it like this. So when you're getting your seatbelt, this is what is there as internal rotation. So yes, you are correct. It's part of internal rotation, part of the slip mnemonic. So subscapularis and the subscapular nerve are the ones that are going to be damaged. Just as elimination, why are the other options not correct? Basically, pectoralis minor is innervated by the medial pectoral nerve, not by the lateral pectoral nerve. And either way, it's the pectoralis major that is responsible for internal rotation. Supraspinatus, we already said, is part of abduction. And teres minor is part of the exit, which is external rotation. Okay, so that is very correct. Good. Next question. So we're having a rock climber who's presenting with weakness in shoulder abduction and also numbness over the shoulder area. Imaging suggests compression in an anatomical space of the posterior shoulder. Which of the following helps distinguish lesions in the quadrangular space from a triangular space lesion? So basically, really the only thing you need to know, the last question is what they're asking about. What's the difference between quadrangular space and triangular space lesions?
Is it A?
Okay, very good. Why is it that?
Because we've got the axillary nerve in the quadrangular space, and it's
Yes.
responsible for innervation of the deltoid muscle.
Yes, very, very good. So let's briefly review the triangles that are there. Essentially, you have the really the boundaries you don't really need to know. You need to more know what are the contents of it. But just for completion's sake, let's go over it. So you have your humerus here. Then you have your teres minor, your triceps, and your teres major that are all forming these areas of, in between these areas, there are spaces. And those spaces, we've named them. The quadrangular space, because it's square shape. Triangular space. And then at the bottom, we have a triangular hiatus. So the quadrangular space, it transmits the posterior circumflex humeral artery, which if you guys remember, when you have surgical neck fractures of the humerus, right? one of the arteries that is impacted is the posterior circumflex artery, right? So this artery is actually coming from this quadrangular space and then wrapping around the top part of the humerus. So that's how you can kind of correlate things and remember that it's the posterior circumflex humeral artery coming out of the quadrangular space. And the artery and the nerve that comes with it is the axillary nerve, which kind of also makes sense because the deltoid region will kind of be here. So the axillary nerve comes and innervates the deltoid. So you mentioned it correctly. The axillary nerve innervates the deltoid. That's why in a quadrangular space region, you would have deltoid weakness. Compare this now with the triangular space. In this space, you only have the artery going, no nerve, which is the scapular circumflex artery, okay, and also the vein. And then you have a smaller triangular hiatus here, which transmits the brachial artery and the deep brachial artery and the radial nerve, okay? Very important to know what passes through what. So this is why the axillary space and the quadrangular space is the correct answer. If there was impairment of scapular supply, then that would be an issue with the triangular space because that's where the subscapular artery comes from. And the rest of them are wrong as well because none of these nerves pass through. Okay, next question. We're having an old man who's having subclavian artery stenosis, but he still has good blood flow to his arm because of a collateral pathway. Which of the following is the best description for the alternative route that reaches the arm? This is a little bit more confusing, so I'll give you some time.
It's
Is it B?
Is it B? Okay, yes, very good. It is B. Correct. Why is it B? Can you explain?
The subscapular artery comes from the axillary, and then the suprascapular from the thyrocervical, and then they will anastomose, basically. That's it.
Yes, very, very good. So what I said that when I initially gave you my advice, you don't need to know most of the arteries, but when it comes to anastomosis, you need to know them very well. You don't need to know all the arteries that are coming out of the axillary nerve. You don't need to know all these details. I'll give you guys the key things that you need to focus on, okay? The axillary nerve itself is a big nerve, axillary artery is a big artery that comes from the subclavian. And you can divide it into 3 segments, okay? You have the first part of the axillary, which gives you the superior thoracic artery. Loki, you don't really need to know about it, so forget about it, okay? Then comes the second part of the artery. This second part of the artery gives you 2 branches, okay? The thoracoacromial artery, also honestly don't need to know about it. But the second part that comes out of the second part is the lateral thoracic artery. This is an artery you need to know about because they ask about it all the time. Why? Because the lateral thoracic artery, it supplies the serratus anterior muscle and the breast, okay? So very, very important, the lateral thoracic artery comes from the second part of the axillary artery, okay? That's the only thing you need to know about them. Then we get to the third part of the axillary artery. Oh, also another thing you need to know about the second part is that this is second part of the axillary artery is what we use as a reference for the brachial plexus. Okay, and we'll get to that later on. And then the third part of the axillary artery, you basically have posterior circumflex humeral artery, which we just discussed. Through which space does this artery go?
The quadrangular space.
Yes, very good. So this, again, it's a branch of the third part of the axillary artery. It's going to go through the quadrangular space along the axillary nerve. We just discussed this, right? Then you have another branch coming off. You can forget about it. This is the one you need to know, the subscapular artery, sorry. This subscapular artery from the third part of the axillary artery is what is going to help you make the scapular anastomoses. So let's briefly discuss this. Unfortunately, I don't have a mnemonic how to remember this. You just kind of have to memorize it. But I think at this point, you guys have gotten it over like so many times, it should be in your mind. But quickly to recap, you have your subclavian artery, which is going to give you your thyrocervical trunk. This thyrocervical trunk is going to give you 2 branches. The suprascapular artery, supra above, okay, suprascapular artery, and your deep transverse cervical artery. Both of these arteries are going to come downwards and they're going to anastomose with the branches that are coming from the third axillary branch. So this is the third part of the axilla. You have your subscapular artery. So you have sub going with your supra. Both of these are going to anastomose. This one is going to give you the subscapular artery, will give you circumflex and thoracodorsal, and those will then anastomose. The shortest way and the most effective bypass, why are they talking about bypass? Normally, you're supposed to go from the axillary artery, first part, second part, third part, you're supposed to go across the entire, length of the artery. Let's assume you have a clot now somewhere in the axillary artery. So the way it can bypass, it actually goes, let me actually clear the drawing so it can show better. Okay, so the way it's gonna go is now this part is blocked, right? So we're gonna go from the thyrocervical trunk, we're gonna go downwards from the suprascapular artery, and we're gonna anastomose with the branches coming from the subscapular artery. So this area here is gonna cause the blood to move and bypass this obstruction, and it can still go and supply the rest of the shoulder. Okay, that's why in this patient, he was still able to have normal shoulder functions, even though he's having obstruction there. Okay. So suprascapular artery plus subscapular artery from the origins that we already talked about. Okay, so yeah. Now, why is E wrong? Can anyone explain? Both of these arteries are also part of the scapular anastomosis. Why is E wrong though?
Because they both come from the same part of the axillary artery, so like it won't like for an anastomosis it has to come from another side too. So if it's both coming from the same side, then it won't reach the other side anyway. So it won't make a difference. It won't supply that part.
Yes, very, very good. Anastomosis means a connection between two different arteries. If both of them are coming from this artery, if there is a block, there is nothing to supply the distal end. They have to come from both aspects. Very good. Okay, good. Next question. So we're having a man coming with a stab wound. He cannot raise his arm above the horizontal. So this is the horizontal. He cannot raise his arm above it, okay? And he's having the condition shown in the image. Which of the following structure of the brachial plexus is most likely damaged? What does the image show you, first of all?
Wing scapula.
Very good. What's the nerve associated with it?
Long thoracic.
Very good. Where does the long thoracic nerve stem from?
C5, C6, C7.
So which is the answer of this?
Serratus anterior, which is roots. Yeah.
Yes, very, very good. So now we're going to talk about the bulk of the thing, which is the brachial plexus. But honestly, it's kind of simple. This is something that we were taught in pre-med. So let me first draw how you can draw the simple brachial plexus in 10 seconds, okay? Sometimes I saw someone was like drawing and like more complicated with the like other branches that are coming out from the main brachial plexus. You don't need to know that much details. You need to know the main terminal branches and the long thoracic nerve. So let me quickly draw it and then I'll explain how I do it. So you're going to have 2 greater than signs, make 3 long lines. Then you're going to have, remember to drink cold beer. So the T you're going to leave empty, then you're going to go to the D. Strikes is better than spare. At the B, you're going to make 2 short waves and then 1 long wave. And then you're just going to connect it as mu. So with this, you're done with your brachial plexus. This is all you need to know. Okay, so what did I just do? Basically, you have your C5, C6, C7, C8, and T1 nerve roots, right? So if you look at this image here, this I have to give a shout out to Dr. Safwan Abbasi. I don't know if you guys know him, but he taught us in pre-med. He's now a general surgery resident at Mayo Clinic, but he taught us this, and this is his slides. And we always just knew him as the brachial plexus guy. We didn't even know his name because he taught it so well. So I'll show you what he told us, okay? So basically you're having C5 and C6 nerve roots that are joining together. This is what's going to give you 1 greater than sign. You have your C7, which is just going to continue on its own, and C8 and T1, which is also going to join together. The roots are going to join together to give you each trunk, okay? So that's why 2 greater than signs, okay? And then 3 long lines coming out of it, which is going to give you your trunks. Your trunks, your superior, middle, and inferior trunks. After your trunks come your divisions. What is happening with the division basically is that you're having each trunk gives you an anterior and a posterior division. So anterior, posterior, anterior, posterior, anterior, posterior. But instead of remembering that, what you can just remember, you've made 3 long lines, right? Just make an X and make a slash. So what if you play bowling, when you have a strike or you hit all the bowling thingies, you get an X. If you only hit some of them, then it's going to be a slash. So strikes is better than spare. That's how you can remember it. Make an X, make a slash. That's what's going to give you your divisions. And then these divisions are going to join together. The anterior divisions here, you can see, will join together to give you your lateral cord. All 3 posterior divisions will join to form posterior cord, and your anterior division will move on its own to form the medial cord. Now, lateral, posterior, medial, this means that it has to be in relation to something, right? Which artery did I say? Which part of the artery is going to be the relation of the brachial plexus? We mentioned it before.
Axillary.
Axillary, very good. So the second part of the axillary artery is where your cords, your brachial plexus cords are going to take its reference from. Okay, they're going to move either laterally to the artery, posterior to the artery, or medially to the artery. Okay, and then you have your terminal branches. Now your terminal branches, the way was basically you make 2 small waves coming from the bottom. Okay, and one long wave all the way from the top joining the middle. So this is how you can see actually it's following how the terminal branches are going to be drawn. So the mnemonic was MARMU, which is your musculocutaneous nerve, your axillary nerve, your radial nerve, median nerve, and ulnar nerve. So the way that Dr. Safwan taught us was remember to drink cold beer. That's how you know roots, trunks, divisions, cords, and terminal branches. And he gave us the mnemonic instead of Marmu. That's how I just kind of remembered it. But he gave us the mnemonic, my auntie robbed my uncle. So whatever is better for you, you can memorize it like that. So let's just quickly go over it again just to make sure. Like, see how this is the exact same thing? 2 greater than signs, make them 3 long lines. Then remember to drink cold beer. So T's you're going to leave empty. At the D, make an X, make a slash. Strikes is better than spare. And at your terminal branches, make 2 small waves going like this and connect the top to the bottom. So this is how you know musculocutaneous is coming from this. Your axillary nerve is part of your posterior cord. Then comes your radial, which is also part of your posterior cord. Your median is going to have a contribution from the top and from here, and your ulna is going to come here from the medial cord. Okay, so this is the same exact thing what we just discussed. It's just an easy, quick way in your exam just to draw them quickly, because some of the questions will be like, oh, which terminal branch is coming from the posterior cord? Then you can quickly draw it, and then you know what to do. Okay, is this clear so far? Or did I confuse you more?
It's clear.
Clear? Okay, great. Now, this is basically all the divisions, the extra nerves that are coming. You don't need to know all of them. Okay, the only thing I want you guys to know is 2 things. Number 1, the long thoracic artery is stemming directly from C5, C6, and C7 roots, which is why in this question, the answer was the nerve roots. They're coming from the roots. The second thing I want you guys to know, because this is something that they ask about in the booklet, is that the divisions are the only section of the brachial plexus where no nerves are coming out from. Okay, all of the rest, they have them. Do you need to know all the nerves coming? No, don't waste your time on it. Okay, focus on the terminal branches, know your terminal branches very well, and know your long thoracic nerve. Okay, this is all I wanted you guys to know from the brachial plexus. Unfortunately, you also need to know the root values, and this is something that doesn't really make sense. Like, even if you try to trace it back, it helps you, but then at some point it doesn't make sense. Unfortunately, this is something you just have to memorize, and I have no mnemonic to give you. You just have to memorize it, okay? You have to know your median is by this, your musculocutaneous, just memorize them, okay? But it's very important to know that because it'll bring questions from it. Okay, so let's see if you understood this. Can someone answer this? We have a female presenting with improperly fitted axillary type crutches. So it's the crutches that go up your axilla. And she's putting pressure on the posterior cord of the brachial plexus. Which terminal branch would be affected? It's a little bit of a trick question.
Radial?
Okay, very good. Why radial? Why not axillary?
I'm not sure. It's just a repeated question, so I know.
Okay, fair enough. Okay, does anyone else know? Okay, no worries, I'll explain it. So basically, again, if you're drawing your brachial plexus, you will realize that, let's do it like this, strikes is better than spare, 2 short waves and 1 long wave. So this is your posterior cord, and you will see that you have 2 nerves coming from the posterior cord, which is your axillary and your radial, right? But the main one really is the radial nerve, because the axillary is also getting a contribution from the top one, okay? So the main one that is affected by the posterior cord is the radial nerve. So this is what you will see here, okay? The radial nerve. Now, why is it axillary type crutches and it's not axillary nerve? Basically, this is called the Saturday night palsy or crutch palsy. Basically, what's happening is, remember we said we have a quadrangular space, we have a triangular space, and we have a triangular hiatus, right? Or I think in Dr. Olena's slide, she called it triangular interval, something like that, okay? Either way, this small one here, we said transmits the radial artery, okay? The quadrangular space with the axillary nerve is more towards the top. It's more superficial in a sense. It's deep, but it's more superiorly, let's say it like that. Whereas the radial nerve is more deep, but it's more inferiorly. So if you have axillary crutches, which are improperly fitted, and you're constantly having the crutches here and you're putting your entire body weight on it, it can compress the radial nerve here. And the radial nerve innervates all the extensors of your forearm. So this motion here, extension, is all done by the radial nerve. If the radial nerve is damaged, okay, what clinical sign will you have? You're unable to extend, so it's going to drop down. What is this called?
Wrist drop.
Wrist drop. Very good. So you're going to have wrist drop. So it's called Saturday night palsy because sometimes when people go out and party on Saturday and they get drunk because Sunday is free for them, they can fall asleep with the arm over their, over their chair, and that can also compress the radial nerve. So very good, very good. You guys got this correct. But I hope the concept is clear now. Okay, next question. While putting metal panels on the roof of a barn, one of the panels slips out of the hand of the man of the roof. During the attempt to catch the panel, the worker below is struck with this sharp edge. The panel hits across the anterior surface, so your anterior surface of the right arm at the mid-length, and the impact severs all the tissues to the bone. When examined in the emergency room, it is noted that the patient can only weakly flex. So this flexion, he can only weakly flex his elbow and the lateral side of his forearm. So this is your forearm. The lateral side is numb. Which, in addition to the muscles, which nerve is injured?
Musculocutaneous.
Yes, very good. What is the muscle that is supposed to be flexing that they're talking about
Uh,
he's unable to flex?
uh, Brachialis.
Yes, very good.
Biceps, brachia, all the
Yes.
flexors basically. Yes.
Yes, very, very good. So here what you need to know basically is that your musculocutaneous is innervating your flexors of the arm, okay? And it innervates sensory, the lateral portion of your forearm. Very good. So let's briefly cover the terminal branches and go a little bit into details of them, okay? So I said that when the nerves are coming out, the terminal branches from the brachial plexus itself, remember them as marmu. For the sensory innervation, just take the first M of the musculocutaneous and move it to the middle, okay? So remember the sensory innervation as armu, okay? Why is that? Because let's go from the top, okay? The first thing that is coming out is the axillary nerve. We know the axillary nerve supplies the deltoid. So it makes sense that it should also supply the same sensory area. So the area of the shoulder is done by the axilla. Then all the back of your entire arm is done by the radial nerve, so R. Then you have your musculocutaneous, which is supplying the lateral part, which is the part like on the side of your thumb, the lateral part of your forearm. And then you have, so this is going to be your M, and then you have your radial nerve also going to the dorsum of your hand, and the median nerve is going to supply the lateral 3 fingers of your forearm. So we're talking about lateral and medial when we're talking about the anatomical position, right? So normally you're standing like this with your hands like this. So your thumb side is lateral, your whatever fingers are like on the side towards your midline, that's the medial side. So the median nerve supplies the lateral 3 fingers and the ulnar nerve supplies the medial 2. How can you remember that? At this point, you've like done it so much, but still, if you struggle with it, if these 3 fingers, if you look at it, okay, 1, 2, 3, it forms an M. So that's how you can remember that these 3 are supplied by the median nerve, and a lot of things, all the sensory distribution in this, even the muscles that are closely related to the thumb, also going to be supplied by the median nerve. That's how you can remember them. Median is these 3 forming an M. And if you look at it, these 2 fingers, they form a U. So that's how you know it's supplied by the ulnar nerve. Okay? That's how you know the sensory distribution. Marmu, the terminal branches becomes armu. Okay, is this clear?
Yes.
Okay. So now what I want everyone to do is we've discussed the sensory innervation, but I want everyone to tell me what is one important muscle that you need to remember for each terminal branch. So axillary nerve, what's the important muscle to remember?
Deltoid.
Deltoid, very good. The teres minor is also innervated by the axillary nerve. Again, what's the function of the teres minor? Let's see if you remember.
Lateral
External
rotation.
rotation.
Yes, very good. External, so exit, that's how you can remember it. Good. Radial nerve, the important thing you need to remember is the triceps and what else in the forearm?
Brachioradialis.
Yes, also brachioradialis, very good. It's the
And
only
the
exception that
extensors.
doesn't flex the elbow. It flexes the elbow, but it's the only one that is not innervated by musculocutaneous. It's innervated by radial. Very good. And for the extensors, what I was hinting at is that the forearm, all the extensors of the forearm, which does this motion, is done by the radial nerve. You don't need to memorize all the names. It's in the name itself. Extensor, 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 extensor. Digitorum, digimini. It's just telling you which of the fingers it's extending. But all you need to know, if you see it in the option extensor, you know it's radial nerve. Okay, except for the exception that I will tell you guys later on. Okay, good. Then musculocutaneous, Huda already mentioned it before, biceps and brachialis, and the lateral part is innervated. Median nerve, what's an important thing to know about the median nerve? Which muscle does it supply?
Intrinsic muscles of the thumb.
Intrinsic muscles of thumb, yes, correct, which are the thenar muscles, very good. It also, so extensor is by radial nerve, flexor is by median nerve, okay? So that's what you need to know. Forearm flexors is by the median nerve. And again, the flexors, you will discuss them later, but you don't really need to know all the details of the names. It's the thenar muscles here. And I said, these 3 are sensory distribution, right? So this thenar on the thumb side is going to be also the muscle distribution. And then the first and second lumbricals, we'll talk about that later on. Ulnar nerve, the one thing I want you guys to know is flexor carpi ulnaris. It's one of the flexor muscles in the forearm, which is not innervated by median. It's innervated by ulna. And all the intrinsic muscles of the hand, which are the hypothenar and the intrinsic, we'll discuss them later on, okay? That's what I need you guys to know for the terminal branches. And this is very, very, very important because all the clinical things will come from this, okay? Okay, I hope this is clear so far. Then let's go to the next question. Any questions, just interrupt me, okay? So we're having a newborn delivered via forceps, which is basically like placing something around the head so you can pull it easier. And during difficult labor involving shoulder dystocia. So shoulder dystocia is that the shoulders get stuck during delivery, okay? And on examination, the infant's right arm, okay, oh, this is my right. It hangs by its side. This means it's adducted, okay? It is medially rotated, okay? And the forearm is extended and it is pronated. So this is supination. You're holding a bowl of soup. If you cannot supinate, it's pronated, which is this way. So this is kind of the deformity. I don't know if you guys can see it. Do it like this. Oh, well. Okay, this is the deformity we're talking about, okay? So which of the following best describes this injury? What is this clinical sign? This one.
Waiter's hand or something.
Yes, waiter's tip deformity, very good. What's the condition that's associated with this?
It's the upper trunk basically that's of the brachial plexus that's damaged.
Yes, very good. So it's the upper trunk that is going to be impacted, which we call as Erb's palsy. Okay, so it's the upper root or the trunk that can be impacted. Okay, and the way it works is that basically either during difficult delivery, like here, you're pulling on the neck of the baby, or if you have a horse rider injury and you fall directly onto your neck and you see this angle here becomes very long. So the way you injure yourself is by having an excessive increase in angle between the neck and the shoulder. Okay, what is gonna be damaged? The C5, C6 roots and the superior trunk. Okay, then the nerves that are affected are the suprascapular nerve because it comes from the superior trunk, and the axillary and musculocutaneous because if you guys remember, we said marmu. These two are gonna be impacted, okay, from the first part. Now, what is the way it's gonna present? You know that axillary nerve is there for adduction, right? I'm supraproud, so it's supposed to adduct. If you're unable to abduct, sorry, if you're unable to abduct, it's gonna be adducted, okay? So that's why you have adduction. And you also have the injury to the musculocutaneous nerve is what's gonna allow you. Normally, the biceps. What is another function of the biceps? In addition to flexing the arm, what's another function of the bicep?
Supination.
Supination, very good. So if you're unable to supinate, it's gonna go and it's gonna pronate, okay? So that's why you have pronation of the tip. So this is what's called the waiter's tip deformity. It's like, give me a tip kind of thing. So that's how you can remember it. Yeah, so this is what is gonna be as Erb's palsy, very good. So you just need to know it's upper trunk issue. Okay, next question. Okay, a 2-year-old infant is brought to the clinic, evaluation for poor hand movements because of a difficult breech delivery. Again, an issue with delivery. Physical examination reveals weakness of hand and wrist flexors. There is hyperextension at the MCP. So these ones here, your knuckles are MCP. This one here, these ones are your proximal, the PIP, and the top one here, like this, is your DIP, okay? So you're having hyperextend. This is flexion, this is extension. So you're having extension of your MCP and flexion of all fingers of the IPs. So your hand is basically like this. The grasp reflex is absent. The grasp reflex basically is, you know how babies, when you stroke they're holding their hands, okay? When you sometimes stroke your fingers, they automatically grasp, right? They automatically like cuddle your finger, right? This is a reflex that newborns have, okay? In this patient, the reflex is absent. This means he's not able to flex them properly, okay? So we said hyperextension of MCP, flexion of all the IPs, okay? And also mild ptosis is noted. Which of the following describes the site of the injury and the effective neurological findings?
C.
C. Injury to the lower trunk, loss of intrinsic muscles, and sympathetic fibers. Correct. Why? What's this condition?
Klumpke's paralysis or something. The lower trunk is basically damaged. You have Horner syndrome basically because of the mild ptosis, and then claw hand is claw hand is basically a symptom too.
Yes, very, very good. So basically, it's Klumpke's palsy, as you said. The lower trunk is going to be impacted. Injury, again, it's either excessive stretching of the arm superiorly. So it's either because of difficult delivery, or if, like, an adult is falling from somewhere and he tries to grab onto himself and then his arm is pulled, excessive stretching of the arm superiorly is what can cause this injury. the C8 and T1 roots can be affected. Usually when T1 is affected, that's when the sympathetic chain is impacted. Okay, and that's when you have Horner syndrome, which is ptosis, meiosis, and anhydrosis. Okay. The nerves affected are ulnar and median nerve, and especially the muscles that are involved are the lumbricals. So I'm going to be talking about them later on when I talk about the intrinsic hand muscles, but just to briefly kind of explain, this is what I was talking about, right? So this is the MCP, okay? Normally, your lumbricals help flex this part, but if you cannot flex it, it's the opposite. Like I said, like it's an English comprehension. You just need to know the opposites, kind of. If you cannot flex, it'll automatically be extended. Normally, the lumbricals are supposed to extend these fingers. Now it's not extended, it's flexed. So the opposite is happening. And you have this claw hand, okay? One thing to note, which is very important, and it differentiates it from ulnar claw, which we'll talk about later on, is that all fingers are impacted. Your entire hand is like this. Whereas ulnar claw, it's only these two. We'll talk about that later on. Anyways, is that clear so far? Okay, we've done a good chunk. This was probably the more heavy one. Is everything clear so far?
Yes.
Yes.
Okay, just bear with me a little bit. Okay, we are gonna do 10 more questions on this and then we'll go to the hands. Okay, this should be easier now. Basically, medical student is following, and you see that he cannot move his hand properly. X-ray is shown. What did the X-ray show?
Mid-shaft fracture.
Yes, very good. Mid-shaft fracture. So what's the answer to this question? Which clinical sign would you most likely find?
Weakness in wrist and elbow C.
Yes, very good. C. Why? What nerve are you talking about?
The median nerve.
Median nerve? Median nerve
Sorry,
is there
sorry,
for extension.
what was it? 1 second. Radian nerve, sorry, yeah.
Yes, very good. Radial nerve. Okay, let's discuss it. Basically, you have 4 places where your humerus can get fractured. The top part here, the surgical neck, mid-shaft, like in our patient, supracondylar, and then the medial epicondyle. So what you need to know about each fracture is what is the injury associated with it, okay? The way I remember it is arm, okay? So your humerus is part of your arm. So A is going to be there with surgical neck fracture, which is basically axillary nerve damage. Mid-shaft fracture is R, which is radial nerve. And then supracondylar fracture is M, which is median nerve. This is how you can remember it, okay? Arm, because humerus is part of your arm. Now, you also need to know what are the arteries that are impacted. And the way you can remember it is the humerus profoundly bleeds. It's not the correct grammar, but just know it, okay? The humerus, which is the top part here, which is the posterior humeral circumflex artery. Remember how I said that when it comes out of the quadrangular space, one of the borders is the humerus, right? So then it's going to wrap around. And if you have a surgical neck fracture, then you're going to have a posterior humeral circumflex artery damage. So the humerus is damaged in the surgical neck. Next one is profoundly, which is the profunda brachii artery, which is the deep brachial artery, okay? Very important that this one is with the midshaft. Compare it to the normal, the brachial artery, which is there for supracondylar fracture. So humerus profoundly bleeds, okay? Humeral circumflex, profunda brachii, and brachial artery for all of this. Is this clear so far? Does this make sense?
Yes.
Okay, great. So this is how you can remember it. And again, like in the transcriptions, it's guaranteed you're gonna have questions on this. Okay, so we've already talked about this. If you know supracondylar fracture, like up top here, you're gonna have issues with abduction because we already talked about it. Let me go over the next one. Radial nerve with midshaft fracture, we already talked about. You're gonna have basically wrist drop because your extensors are involved. And your artery that's going to be damaged is the profunda brachii. Humerus profoundly bleeds. Okay, next, so back to this question, basically, why is this radial artery? Because this one, the loss of abduction and deltoid wasting is talking about axillary nerve. And axillary nerve is going to be part of surgical neck. Clawing is going to be part of ulna, and inability to oppose the thumb will also be supracondylar fracture. We'll talk about it in just a bit. Okay, good. Next question then. Okay, so a 45-year-old woman, she is involved with accident and is thrown forward over her handlebars. She lands directly on her outstretched hand, okay? She's brought to the emergency with a visible deformity and swollen elbow as shown. Right forearm is pale and cool to touch. She experiences intense pain with any movements. Capillary refill is delayed. There is diminished sensation over the lateral palm and digits. So lateral palm is this part, these 3 fingers. X-ray confirms a fracture just above the elbow joint. Which of the following describes the injury and the structure is damaged?
C.
Oh, C.
C. Supracondylar, yes, median nerve and brachial artery. Correct. Why is it not B?
Because the profunda is higher up, the midshaft
Yes.
would damage it.
Yes, very good. So again, humerus profoundly bleeds, okay? So the profunda is going to be the midshaft, bleeds, the brachial artery will be there for supracondylar fracture. Very good. Now I have a question for you guys. The forearm is pale and cool to touch and capillary refill is delayed. What is this indicating?
Blood is not reaching.
Blood is not reaching. Very good. So there's vascular compromise to it. Okay. What is this image showing you?
Volkmann's contracture
Very good. What is Volkswagen contracture?
is when we've got lack of blood supply into the forearm. As a result, the muscle contracted.
Very good, very good. That's basically what is there. So C is the thing. And one thing that I want you guys to know is that Volkmann's contracture can also result in something known as compartment syndrome, which is why his capillary refill is delayed and his arm is cool and touch. Most important, the most indicator for this is intense pain with any movement. Pain that is out of proportion can be a sign of compartment syndrome. Compartment syndrome is basically, let me actually explain this first. So supracondylar fracture, we said, arm, the median nerve and the brachial artery will be damaged, correct? If the median artery itself is only damaged, you will have the hand of benediction. I'll talk about this later on. If your brachial artery, however, is injured, what's going to happen is you're going to have loss of blood supply to the arm. This bleeding and sometimes also all the inflammation and everything that's going on can cause rapid swelling of the forearm. And unlike your abdomen is free. It doesn't have that's why you can get fat easily, or that's why you can get pregnant and your abdomen can distend, because there is no covering that is limiting the space of how much there can be of an extension. Whereas in your arm, there's a fascia that is limiting how much you can extend. So when there is swelling below this fascia and it keeps swelling, there's going to basically be within that compartment, there's going to be pressure and collapse of that of the vessels even more. So it's going to even further reduce the blood supply. So that's why it can cause ischemia to the digits, okay? So that's an important thing to know as well. One of the, complications of supracondylar fracture is compartment syndrome. Now, Volkmann's contracture is basically what's happening is now after a long time, you're going to lose all the blood supply to your flexors and all the muscles of the forearm and the hand, and it's going to cause you this fixed flexion deformity. What does this mean? This means that it's a contracture. So basically your hand is stabilized in that way. It cannot move any different. Even when you try to extend it, it was not going to move, which is different than wrist drop. What's the difference between this, okay, my Volkmann's contracture, okay, and wrist drop? What's the difference between them? They kind of look the same.
Your extensors are not working in the wrist drop.
Yes, very good. The cause, number one, is different. And number two, Volkmann's contracture is fixed flexion deformity. So it's fixed in place. Even if you try to extend, it's not going to move. Wrist drop, it's flaccid. Your extensor not moving. If I move my hand, it's going to move normally. It's just that these extensors are not able to work. But in Volkmann contracture, it can look similar. That's why I didn't want to make this distinction clear. You're having a fixed flexion deformity. Okay, good. I think it's enough about this. So this is just a summary of all that we talked about of the humerus fractures. Okay, next question. This should be an easy one. So within the deeper portion of the cubital fossa, which of the following statements is correct in regards to position of the median nerve?
Is it B?
B, it lies medial and deep to the upper nervus. Very good. What are the contents of the cubital fossa?
We've got the nerves, the arteries, and veins.
Yes. So the way you can remember it, honestly, the borders you don't really need to know most of the time. The only thing you need to know is that the roof is formed by the biceps aponeurosis, okay? And the contents, that's what's important. The way you can remember it, oh, it covered it, but the way you can remember it is either the mnemonic, which was by Dr. Olena, the MBBS, or the way I like to remember it is my blood turns red. So from most medial to lateral, my blood turns red. It kind of made it easier for me because already I'm talking about humerus profoundly bleeds. So I kind of continue that analogy of the bleeding and continue it in the cubital fossa. My blood turns red. Median nerve is the most medial. B is the brachial artery. T is the biceps tendon. And then my blood turns red. R is the radial nerve. Okay, so you need to know which are the relations, and that's why the brachial artery is not lateral to the median nerve, it's medial. That's what's correct. It's not superficial to the aponeurosis because the roof is the aponeurosis. The contents are below the roof. So that's why it's deep to the aponeurosis. The D is basically, it is true that it's medial to the biceps tendon. And also what is true is the median nerve goes in between the pronator muscle. The thing though is the question is asking you about the cubital fossa. This piercing of basically after the median nerve exits the cubital fossa, it then only enters into the pronator muscle, okay? So that's why the statement is true, yes, but it's not the correct answer to the question because it's happening after the cubital fossa, not within it. Okay, this should be easy. Now, next one. 2-year-old boy to the ER. Parents are playfully swinging him. After a short while, he is crying. He refuses to move his arm and holding it in a slightly flexed, and supination pronated position. So it's kind of holding it like this. There is no swelling or bruising. What most likely happened in this? This is very classic. You're gonna get for sure this question.
Annular ligament is completely
Yes.
torn.
Mm-hmm. So is it torn or is it something else?
It's probably slipped out, yeah. So
Yeah.
the radial head slipped out of the annular ligament, yeah.
Yes, very good. So the answer is E, correct. The ligament is very strong, so it's less likely to tear. Most of the time, it's just the radial head is actually moving out. So this is what we call nursemaid's elbow. Basically, long story short, you're having the radius, the annular ligament that is there around holding the radius in place. If you pull excessively on the child's arm, either you want to save them from something or you're just swinging them, you can pull this ligament out. It's not a big thing. You can just literally like reposition it, and it's fine. So this is just what you need to know. It's not necessarily the rupture. Most of the time, it's slipping out. Okay, good. Next one. Supination of the hand and forearm, supination, would be diminished by the loss of the radial nerve, but one powerful supinator would still remain intact. Why? Which one is it, basically?
C.
C, biceps brachia. Okay, why?
Because it's innervated by muscular cutaneous.
Very good. What are the two muscles that you need to know for supination?
Supinator and biceps brachii.
Very good. What is the supinator innervated by?
I'm not sure, but I guess medial.
Radial nerve. So that's why in this question, the loss of the radial nerve would affect the supinator, but it would not affect the biceps. You got this question correct. Very good. The rest of them are also innervated by the radial nerve, but it's going to be there for the flexion of the forearm, not for the supination. Very good. So all I need you guys to know for this, this is something Dr. Atif mentioned, so I'm assuming he's going to bring this. Basically, the arm movements, you have flexion, you have your biceps brachialis and brachioradialis. The most important, the chief flexor is the brachialis. Need to know that. Extensions by the triceps. Then you have your pronator muscles, which are innervated by the median nerve. And more important, what they ask about is the supination. Supinator is by the radial nerve. Biceps is by the musculocutaneous. And the chief supinator is the biceps. So if you know these two things, I think you should have more than enough from this slide. Okay? Okay, next question. Worker is doing repetitive lifting, develops a tennis elbow. The focal point of pain would likely be near which palpable bony landmark?
A.
A. Okay, easy. This was easy. Okay, what would it be if it was C?
What is that? The other one, golfer.
Yes, very good. So this is also an easy question, but you will get this. Basically, tennis elbow. So what you need to know about the forearm muscles is basically at the medial epicondyle, the flexors of the arm are there. Okay, that's what allows the flexion. Whereas at the lateral epicondyle, the extensors of the forearm are there. So if your medial epicondyle is affected, it's going to affect the flexion. If your lateral is there, it's going to affect the extension. And the reason is kind of tennis people, like if they're doing their backhand, imagine him just extending his arm like this. So that's going to put a lot of pressure on his lateral disc. Whereas a golfer is going to flex a lot trying to, tuck, like he brings the golf ball to swing the golf ball. So that's why his medial will most likely be impacted. Very good. So it's just lateral epicondylitis, medial epicondylitis, wrist flexion movement and extension movement are going to be impacted. This is an easy question. Good. Which muscle in the superficial layer of the anterior forearm is not innervated by the median nerve? This is also more recall because forearm is more recall and not clinical. Sorry?
B.
B. Very good. So for the forearm muscles, there is lots of names. Okay, you don't need to know all the names. I'll give you what you need to know. You need to know that the forearm has 3 compartments. Okay, superficial muscles, intermediate muscles, deep muscles. In the superficial ones, you have probably you guys already know this, the PF muscles. Actually, you don't need to know this for MCQ, but for OSP, you guys have OSPs or OSPs? OSPs. I think for OSPs, you'll need to know this. But either way, it's in the name kind of PF. You're doing flexion. Okay, and there's also pronator. So what you need to know is this flexure, we said all of them are innervated by the median nerve, except basically what I need you guys to know is whatever is on this hand side. The flexure carpi ulnaris is innervated by the ulnar nerve. Kind of makes sense. Ulnaris is what? It's next to the ulna. The ulna is here next to your pinky. So the one that is close to your pinky, we already said that these three are innervated by the median nerve, sensory wise, these two by the ulnar nerve. So the same thing will happen for the muscle. Whatever muscle is there on this ulnar side will also be innervated by the ulnar nerve. So that's why your flexor carpi ulnaris is innervated by the ulnar nerve, rest of the median nerve. That's all you need to know. Now this second intermediate layer, you need to know this, okay? Basically what you have is you have your flexor digitorum superficialis, which is this muscle here. It goes to the flexor retinaculum, and it has its tendons basically going and attaching to the proximal interphalangeal joint. So we said this one is MCP, okay, your knuckles. This one, wait, this one is your PIP, okay? And then the distal one is your DIP. So for me to do this is done by my flexor digitorum superficialis, okay? This is innervated by the anterior interosseous nerve, which is a part of the median nerve. Very, very important. Flexion of the PIP by the anterior interosseous nerve, which is by the superficialis muscle. Now, in the deep layer, you have basically the same thing, the same muscle, but it's now the deeper muscle. So flexor digitorum profundus, deep. It also extends its tendons to the digits, but what's important is it extends it all the way so you can flex your DIP. So for me to do this, I can't do it with the other fingers, I can only do it with this one. This one is going to be by DIP. This one is by flexor digitorum profundus. This one is by superficialis. And what you need to know about the FDP is it has dual innervation. Again, medial half is going to be innervated. The tendons that are going to this side are innervated by ulnar nerve. The tendons that are going by this side are innervated by the median nerve. So dual innervation for the flexor digitorum profundus. Okay, I hope that makes it clear. The rest of the muscles in the deep layer are also by the anterior interosseous nerve, the median nerve. Okay, that's low-key all you need to know, just the innervations. Extensors, you don't need to know the only thing, forget about this. All you need to know, they have extensors in the name. So you already know, you don't need to memorize each name. What you need to know, extensors of the forearm are innervated by the radial nerve. Two important muscles I want you to know, brachioradialis is part of the flexion of the forearm, but it is part of radial nerve, or innervated by the radial nerve. Supinator is also innervated by radial nerve. We already talked about this. That's all you need to know. Yeah, that's it. Okay, so let's see if you guys remember this. The flexor digitorum profundus muscle is innervated by which of the following nerves?
D,
D, which is both A and B, ulnar and median. Okay. Is it for the profundus? Is it the median nerve that is innervating it, or is it a specific branch of the median that's innervating it?
I'm not sure.
Okay, no problem. Let's go back to this. So if you look here, the superficialis and the profundus, both of them are innervated by the anterior interosseous nerve. The anterior interosseous nerve is a branch of the median nerve, but it's a motor branch. I'll show you guys later on the course. It branches off quite early from the median nerve at the cubital kind of next to it. It branches quite early, supplies the flexors. Whereas the normal median nerve that we call, the deeper one, it just goes deeper and it goes all the way to the hand. So what you need to remember for the flexors is the anterior interosseous nerve. Yes, median nerve is correct, but it's actually a specific part of the median nerve, which is the anterior interosseous nerve. So that's why C is more correct. And also the profundus we said has dual innervation, so ulnar is also correct. So that's what makes E correct. Is that clear? Okay, I'm assuming it's clear.
Yes.
Okay, another question to this. Which of the following muscle combinations is responsible for flexion at the proximal and distal interphalangeal joints, respectively?
C.
C. Very good. So the proximal is by superficialis, the distal is by profundus. That's all I need you guys to know. Okay, and this is really, really important. Profundus has dual innervation, superficialis is by the median nerve. Okay, or the anterior interosseous nerve. Very good. Now we're finally there at the last portion. I hope you guys still have some energy left. This is probably going to be also high yield because all the hand of benediction, ulnar claw, all that is going to come into place. So yeah, I'll be going over it. Yeah, okay, let's do this. This is the last part. Student is rollerblading on the sidewalk. He's trying to avoid, he falls on his wrist, okay? After the fall, he's noting severe pain in the anatomical snuff box, which is this region here. And you see the x-ray. What does the x-ray show you?
Scaphoid fracture.
D. Yeah.
Yeah, scaphoid fracture, very easy. Okay, so what you need to know, very quick, you guys already know this, you need to know how to identify the carpal bones on the x-ray. There's different mnemonics or different acronyms that you can use. The one I was taught was so long to pinky, here comes the thumb. So you start off at the thumb, so long to the pinky, now you've reached the pinky, here comes the thumb, now you've reached the thumb. Other people, they use the she's so pretty, try to catch her, whatever works for you works, but I'm just giving you what helped me, okay? Be able to identify them also on the x-ray. So long to pinky, here comes the thumb. Scaphoid is the one that is most to the thumb side, okay? Now, what we also need to know is what, you need to know 3 main carpal bones. You don't need to memorize the rest of them locally. Like, honestly, like, I would say, yeah, just know the names maybe, but the more important ones are these 3 that you need to be able to recognize on the x-ray itself, okay? Scaphoid, lunate, and hamate. So scaphoid is basically the most common fractured carpal bone, which is the one that we have in our patient as well. What I need you guys to know as well about this is that it's going to present with tenderness of the anatomical snuff box because the scaphoid forms the base of the snuff box. We'll talk about it in just a bit. And what is a complication that can be there with scaphoid fracture?
Avascular necrosis.
Very good. Avascular necrosis. Basically, what's happening is normally you have your arteries that come and they supply firstly the proximal portions and then they supply the distal portions. The scaphoid is special in the sense that it first goes to the distal portion and those distal portions then go to the proximal portions. So if I have my scaphoid area here and I have a fracture right here, the distal portion is going to be still supplied, but my proximal will die off. That's what we call avascular necrosis. It is a complication of scaphoid. That's all you need to know. Lunate dislocation, what you need to know, the most commonly dislocated bone is the lunate. Fractured most commonly is scaphoid. Dislocated most commonly is lunate. Lunate, what you need to see is, for example, here. So we said, so long, this is the thumb, so long to pinky, right? So the long is the lunate bone. This lunate bone, what you see here is, in this area here, you have the carpal tunnel running. So if this lunate bone is dislocated, it can cause injury to the median nerve, okay? Because it's running in the below the carpal tunnel. So yeah, that's what you need to know about this. And the last one is hamate. If you have a hook of hamate fracture, you'll have ulnar nerve damage because the Guyon canal passes there. So most common fractured bone is scaphoid. Most common dislocated bone is lunate. Fracture of the hamate gives you ulnar nerve injury. Those are the 3 things I need you guys to know about the carpals, in addition to identify them on the x-ray. Now, the snuff box basically is this area here. Okay, it's at the base of your thumb. The reason it was called snuff box, I don't know if you guys know, but back in the olden days, they used to have tobacco and cocaine and put them here and then just snuff it. So that's why it's called snuff box. Okay, so you need to know, very important, the what are they called? The boundaries of the snuff box. Okay, which are extensor pollicis brevis, abductor pollicis longus, extensor pollicis longus. I always struggle to remember these, so the way I remembered them is Abby's long snuff extends and brings life. Okay, this might be more complicated, but let me explain. So all you need to know, all of them have pollicis, obviously, because we're talking about the thumb. Well, I just was confused which one is brevis, which one is extensor and that stuff. So what I remember is Abby's long snuff. So snuff is snuff box. Abby is abductor longus. Okay, so Abby's long snuff, and because she's snuffing whatever she's snuffing, it extends and brings her life, or it brings her joy. Okay, so extend is extensor, both of these extensor, pollicis because both are already in thumb. Brings life is brevis and longus. So the extensor has brevis and longus, but the abductor has only the longus. So that's how I remember the borders. If you can plain memorize them like that, go with that. Okay. The contents of it also very important. You have radial nerve going through it, the branch of the radial artery, going through it, a branch of the radial nerve, and the scaphoid forms the base. That's why we said you'll have tenderness, or if you press basically on this snuff box area, it'll hurt them because their bone is fractured. That's all you need to know about the snuff box. Know the boundaries and the contents. Okay, next question. Old woman is tripping, falls on her outstretched hand. There is pain, swelling, and visible dorsal displacement of her wrist. Okay, so moving upward. X-ray shows a transverse fracture of the distal radius with dorsal angulation. Which of the following is most characteristic of this injury?
B.
B, dinner work for deformity. Very good. So this is kind of very classical. It's part of Colles fracture. Basically what you're having is distal radius that's impacted and it can compress on the median nerve. So you've already heard median nerve so many times now. After this, I'm going to be explaining you guys the course of the median nerve. You need to remember that the median nerve is coming from the brachial plexus, all the way from the neck, all the way down your arm, all the way to your hand. So there's so many potential sites of injury that it can occur. Colles is one of them where the median nerve can get damaged, okay? The distal radius. So you will have a dinner fork deformity because basically the brachialis muscle is going to pull up the broken fragment, okay? That's all you need to know. It can damage the median nerve and brachialis muscle pulls it upward. That's all you need to know about the quality fracture. Okay, next question. We're almost done. I think 5 more questions. Female secretary. Secretary is very classic. If I just tell you secretary, you should have something coming in your mind. She complains because of clumsiness, holding object, weak flexion of her index and middle finger, and anesthesia in her thumb, index, middle finger, and lateral part of the ring finger. This is very classic. What is this?
A.
A. Compression of the median nerve in the carpal tunnel. Very good. Why is it not B?
Because I don't know the Guin canal.
Okay, fair enough. The Guyan canal, basically it has the ulnar nerve, okay? And the carpal tunnel has the median nerve, okay? So the thing you need to know about the carpal tunnel, it's between the carpal bones and the flexor retinaculum, okay? And in between that, basically you have 10 things moving through. Most important thing you need to know, the median nerve passes through it, okay? The motor branch of the median nerve to supply the intrinsic muscles of the hand. Now, the other parts that are there are 9 muscle tendons, but it's actually just 3 muscles if you think about it. It's the tendons of the digitorum superficialis, which we said flexes what? PIP or DIP? The superficialis.
PIP.
Could you ask?
PIP, exactly. And it also has the tendons of the profundus, which flexes the DIP, and you have the flexor pollicis longus. So it's actually really the tendons of 3 muscles, but it's like 1 to each digit, so that's why they say it's 9. So that's just to simplify it in your own head, and no blood vessels run through it. That's what you need to know. Okay. Next question. Compression of the median nerve at the carpal tunnel will affect which hand muscle?
Flexor pollicis brevis.
Flexor pollicis brevis. Good. Very good. So let's discuss the hand muscles before we eliminate the other options, okay? So now here's the course of the median nerve that I was talking about. We're starting all the way in the brachial plexus, okay? It's moving all the way downward. So there's so many sites of injuries that can occur, but some are the classic ones that you need to know. One of the sites we already talked about is supracondylar fracture. Remember we said arm? Median nerve is damaged there. That's one of the sites. The other site is here, which is, I said after the cubital fossa, it enters the pronator muscle. So sometimes what can happen is it's in between the 2 pronator muscles, I mean the heads of the pronators. So sometimes when they become overused or like kind of hypertrophied, it can compress on them, okay? So that's another site of injury, the pronator teres muscle. Then you have another part, which is here. You see this branch coming off here very early. This is the anterior interosseous nerve. So remember how I said that it is the median nerve, yes, but it's coming off very early and it's both purely motor nerve, okay? So it's going to supply all the flexors in the forearm except for flexor carpi ulnaris, because that's going to be by the ulnar nerve, okay? So this is another site of injury that can happen. And you need to know all of them. These are the high yield ones even. The flexor retinaculum is at the carpal tunnel syndrome. Okay, a secretary who's typing a lot, who's using the mouse a lot, and something is compressing on her wrist, that can also cause damage to the median nerve. And the last one is just like a very superficial kind of area at the opponent's pollicis muscle. Okay, so here I summarized it for you. What are proximal lesions? What are distal lesions? The conditions and the injury sites. Okay, you guys can go on this on your own time, but we've discussed all of them. It's very, very high yield for you to know this. Okay, now let's get to the intrinsic muscles of the hand. It's actually quite simple, okay? When you look at the hand, I want you guys to think of 3 main areas. The area close to your thumb, the area close to your pinky, and then the intrinsic muscles. So just kind of think of a triangle, okay? So the first part, the muscles that are there, part of your, next to your thumb, are the thenar muscles. The thenar muscle is the same way. I said these 3 are innervated, the sensory, median nerve. So the muscles that are here also, along the sensory distribution, will also be innervated by the motor branch of the median nerve, which we call the recurrent branch, the recurrent medial branch. So these ones, there's actually 3 muscles that are there. Abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. Honestly, the only thing you need to know, it has in its name pollicis, which is the thumb, and both have brevis. What I need you to know is the functions. So abductor, flexor, and opponens. Even from these, opponens is the most important. How can you remember them? All for one. So abductor, flexor, opponens. What does opponent pollicis do? It does this motion. It allows you for opposition, which is basically your thumb being able to go across your wrist. It's an extremely important function that differentiates us from a lot of animals. If I want to grab my bottle, Okay, you get the point. If I want to grab my bottle, it's much easier for me to have my thumb going around it, right? So this is what allows this gripping is only possible through the opponent pollicis, which allows me for opposition. Okay, very important, the thenar muscle. On the hypothenar side, you have the same muscles basically, but what they're called digiti minimi because you're going towards the pinky. And they're supplied by the ulnar nerve. The same way the sensory distribution of these two is ulnar, remember these are also the motor of ulnar. And the way you can remember this is one for all. So all for one and one for all, right? Opponents, adductor, flexor, opponents, and then opponents, flexor, abductor. It's the same thing, okay? And now for the intrinsic muscles of the hand, the tip of the triangle, it's actually two muscles that are within the hand itself, in the deep hand. You have your interossei, which again has two branches. So you have interossei that are on the palmar side and you have interossei that are on the dorsal side. The interossei that are on the palmar side, you know that they cause adduction, so moving your fingers towards each other. Whereas the dorsal one in the back are there for abduction, moving them outward. So the way you guys already know this is pad and dab. So palmar interossei adduction, dorsal interossei abduction. The other muscle you need to know about is the lumbricals. The lumbricals are also special that they have dual innervation. Again, what was the muscle in the flexor compartment that had dual innervation? I'm trying to like cross-reference this so you guys recall it multiple times. Dual innervation of the flexor.
Flexor digitorum profundus.
Very good. So now the second one that also has the dual innervation is the lumbricals. The lumbricals, the lateral side is going to be median nerve, ulnar side is going to be ulnar nerve. Okay. The movement that the lumbricals do is this one here. So Dr. Olina calls it the Z movement. I see it more as an L movement, honestly. So whatever works for you. What you need to know is these are your digits. This is your MCP, okay? And this is your PIP. This is your DIP, okay? So your flexor digitorum superficialis basically is going to go and cross the PIP, and that's why it allows flexion for the PIP, right? And your superficial and your flexor digitorum profundus goes all the way to the DIP, the tendon. That's why it allows for flexion of the DIP. Now, and at the back of it, what allows basically your extension is the extensor hood, okay? Now, what is special about the lumbricals is that the lumbricals actually start off of the tendons. They don't originate from muscles. Usually muscles originate from bones, right? But this is special because it originates, number one, from the tendon. Number two, it actually crosses the MCP on the flexor side. That's why it causes flexion of your MCP. It allows you to flex your MCP. But then the lumbricals cross over to your extensor side and go into your extensor hood. So that's why you're able to flex the MCP, but the PIP and the DIP, they stay extended. Why? Because the lumbricals have crossed over from here to the back. So that's why it causes this like Z movement or L movement that you want to call it. But it's very important as well. Okay? So this is what the lumbricals do. Again, dual innervation. These two are by the median. These two are by the ulnar. Is this clear so far? This kind of a review session mixed with practice questions. Is this clear?
Yeah.
Okay. So if it's clear, now tell me, this is the same question we brought before, and you correctly said that flexor pollicis brevis is the only one that is part of the thenar muscle, all for one and one for all, right? So all for one. So this is part of the thenar, which is median nerve. You said it correctly. Now I want every one of you to give me what is the function that this muscle gives you of the other options, and what's the innervation, as a quick summary. Dorsal interossei does what?
It abducts and it's innervated by the ulnar.
Very good. So dab and ulnar, very good. Next one, flexor pollicis longus.
Flexor pollicis longus. It flexes the thumb. And it's innervated by the median nerve.
Very good. It's innervated by the median nerve, specifically the anterior interosseous nerve, which is coming actually part of the flexors. It's part of the forearm ones. Okay, very good. Opponens digiti minimi.
It opposes the small digit basically, and it's innervated by the ulnar nerve.
Very good. And it's part of the hypothenar muscle, all for one and one for all, right? Palmar interossei, last one.
Same as dorsal interossei, but it adducts.
Yes.
And ulnar nerve.
Yes, very, very good. Okay. Oh no. Okay, well, whatever. Intrinsic hand muscles are innervated mostly by the ulnar nerve, but two lumbricals are innervated by branches of the median nerve that also supply which muscle compartment? So the question is basically, median nerve supplies which of these? And
Yeah. Thenar compartment.
Thenar compartment. Exactly. You guys already saw that. Good. This one now. Now is the hand muscles. 3 more questions and then we're done. Pushing the fingers outwards against resistance tests which of the following pairs of structures?
Dorsal interossei and ulnar.
Yes. Very good. So this is the motion, right? So we're doing so you're trying to extend, basically move them outward. So you're abducting. And if you're just going to add a little bit of resistance, it's just to see is the muscle function really intact or not. Very good. Next question. Patient presents to the ER with a deep cut at the palm of their hand. If the only nerve damaged is the recurrent branch of the median nerve, which movement of the thumb will be lost?
A.
A?
I think
Try
so.
again. Why A?
Because recurrent supplies the, what is it, abductor pollicis longus or brevis. Well,
Okay. Fair. Okay.
I think it's
Actually, but in this part, the answer that I was looking for is opponents. So we're only talking about the abduction. Remember that abduction of your arm as your fingers, like this. Oh, abduction of your thumb is done by the flexor pollicis. No, the abductor pollicis. I forgot the full name of the muscle, honestly. But it's basically the one that is there in the forearm region, okay? And it was done by the anterior interosseous, not by the recurrent branch. The recurrent branch is the one that is going intrinsically to the thumb itself, okay? So the one is abduction, that is correct. Opposition, sorry, which is correct, because that is going to be innervated by those are part of the thenar muscles that are innervated. So let's quickly talk about hand movements. We already did this. MCP is the knuckles here, and PIP, you have the PIP and DIP. And then the hand movements, right? So the thenar compartment is there for abduction, adduction. You can do everything. The one thing I really need you guys to know is opposition. Hypothenar, you can kind of forget about the movements, honestly. But it does the same thing. We said all for one and one for all. It does the same movements. Opposition, it helps with it. But the main one that comes opposition is from the thenar eminence. And then the interossei, we also discussed abduction, adduction, and then the Z movements, right? Okay, patient presents with deep laceration to the arm. On examination, they're unable to hold a piece of paper placed between the index and the middle finger. So my index, my middle finger, he's unable to hold it, okay? When you attempt to pull it away, which nerve is most likely damaged?
A.
Oh,
A, ulnar. Okay, what muscles are we trying to look for?
The interosseous, I think.
Yes, very good. So basically, this is a table that I made based off like the pictures that were there in the presentations. Very, very high yield. This summarizes like 6-7 conditions together. Okay. I removed 2 of them. We'll be discussing them after this. But what I want you guys to know, and this is very important, okay, the movements of the thumb. Again, remember that we said median nerve courses a long way, and it can have multiple signs of potential injuries. Okay. Now, we said one of the injury sites can be with this one here, which is the anterior interosseous nerve. Now, my question was, what's the difference between, basically, at the very beginning, I remember when I said you can't just like memorize MSK on its own, you need to really understand and compare. What's the difference between this and this? What's the difference between opposition and doing this motion? Can anyone tell me? Doing the OK sign. What's the difference? Both of them are circles. What's the problem?
You're not opposing your thumb when you're doing the OK sign.
Yes, very good. It's different muscles that are there different muscles that are working, and also different nerves. So in opposition, okay, in true opposition, you're having the opponent's pollicis brevis working, which is part of the thenar muscle. In the OK sign, what you're actually doing, my God. Okay, in the OK sign, what you're actually doing is, firstly, you're kind of trying to flex, okay, the flexor pollicis longus. You're trying to flex your thumb a little bit. And then you're actually flexing your DIP. So your DIP is flexed by what? We discussed this multiple times. Flexor digitorum profundus. So in order for you to do this, you can see my profundus, my DIP is flexed. And here my thumb is also flexed. So this is what does the OK sign. So I am testing the flexor pollicis longus and the FDP when I'm doing the OK sign. More than knowing the muscle, what's important for you to know is that this OK sign tests the anterior interosseous nerve. Whereas opposition tests the recurrent branch of the median nerve, because anterior interosseous nerve comes much more far, like it comes first, and then the recurrent branch of the median nerve is this one here, which is very distal, okay, which is going into the hand itself. Very, very important for you to know. So opposition is by the recurrent branch of the median nerve. OK sign, which is what she's doing here, but this paper is the anterior interosseous nerve. Now, what's the defect, okay? If you cannot do the OK sign, if your median nerve, if your anterior interosseous nerve is damaged, you're not able to flex your DIP. So it's going to be like this, flattened, which you can see here. This is his normal arm. Here it's flattened. So a flattened pinch is an indication of anterior interosseous nerve injury, which most of the time is because of like forearm fractures, because we said the anterior interosseous nerve branches very up top, okay? So we've discussed this, and we've discussed thumb opposition, which is there for recurrent median. Now, If you're unable to oppose, what is going to happen is you're going to have something known as the ape hand. Ape hand is basically you lose thumb opposition, so your thumb is going to be adducted to your side. So when you're trying to, like, for example, drink your water bottle, you can't. Okay, whatever. So you can't, okay, now it shows. You can't grip around it properly. You're basically going to be gripping around it. Your hands are going to be like this, and you're going to be gripping it like this. This is obviously much harder to do than properly being able to oppose and gripping the bottle fully. So this is what we know as ape hand. You lose thumb opposition, and this is what's going to look like, okay? And this is going to be more with more distal lesions, like in your carpal tunnel, because the recurrent median branch just branches off much later. Okay. We're done with the median nerve for now. Radial nerve, this movement shows a wrist extension. So I'm basically extending, but I'm just adding a little bit of pressure. Okay, that's why your hands are there. So this is just to make sure that you have enough muscle motion. By the radial nerve, it's supplying all the extensors of your forearm. We already discussed the clinical condition associated with if you're not able to extend is going to be wrist drop. Okay? Classic, we said arm. So mid-shaft fractures is very classic for this. And lastly, let's go to the ulnar nerve. The ulnar nerve also has kind of a long innervation, but you don't need to know all of the details. There's two entry sites you need to know. One is up top, which is proximal, which is at the medial epicondyle. And the other one you need to know is at the Guyon canal, which is at the hook of the hamate. Okay? So again, we said the ulnar nerve supplies the interosseous muscle, which are there for abduction and adduction. So in our patient, if you can hold the paper in between and I can pull it, that means your fingers are strong enough to adduct. Okay, that's how you test basically the ulnar nerve. And if you cannot hold the finger, then that means you cannot adduct, your ulnar nerve is injured. Very high yield. So if this table, I think it should hopefully summarize everything for you guys, and you should get the questions correct. Okay, let's go through this as just a quick review. 23-year-old man, he's injured. He's having a displaced distal radius fracture. You see that he can make the OK sign with one of the hands, but is unable to make a round circle with the other ones. No sensory areas loss are detected. What is the nerve damaged? Quickly, you should know this now. C. Anterior interosseous nerve, very good. And this is what I was talking about: flexion of the FDB and the flexor pollicis longus. Very good. And also it says no areas of sensory loss because the anterior interosseous nerve is a purely motor branch. It does not supply any skin. Okay. Is this the last question? I think so. Okay, a 35-year-old man presents with hand deformity. On attempt to make a fist, he's unable to flex the index and the middle fingers. He's unable to flex them. So he's making a fist, but he's unable to flex these. So he can flex these two, but he cannot flex these, while the ring and little finger flex normally. Which of the following correctly matches the nerve injury in the clinical presentation?
D.
D. Also very characteristic. Hand of benediction, median nerve injury at the elbow. So let's quickly discuss the difference between hand of benediction and ulnar claw. Okay, so firstly, what you need to know is that ulnar claw is something that presents at rest. Okay, hand of benediction is an active movement. You would not notice the defect until you ask the patient to move his hand. So when you're making a fist, right, you're trying to use all the flexor, digitorum, superficialis, profundus, everything. You're trying to use the median nerve to make a full fist. Now, when you're trying to do this, okay, we said that the profundus is supplied by is a dual innervation, right? So median nerve these ones and ulnar nerve these ones. So when you're making a fist and you're only able to make a fist with these two, that means that these three fingers are damaged. That means that this is the median nerve that is damaged. So this is what we call hand of benediction. It's like the Pope blessing you, okay? So the median nerve, a proximal injury of the median nerve can give you the hand of benediction. It kind of looks similar to the ulnar claw, but what's the difference? In ulnar claw, it presents to you at rest or at extension of the hand. So now, I'm presenting to you like this, okay? My fingers are fixed like this. Why is that? It's because the ulnar nerve is going to lose the lumbricals. We said the lumbricals are also the other muscles that are innervated dual. So the ones that are on this side is by ulnar nerve, the ones that are on this side is by medial nerve. So the lumbricals in this part, they are not able to extend it anymore, okay? Because we said that it flexes the MCP and it extends the PIP and the DIP. So now, you're not able to flex the MCP anymore because of the lumbricals, so it's going to be extended, and your PIP and your DIP are going to be flexed. This is what's going to give you the ulnar claw. And when you try to this is what's going to give you the ulnar claw at last. That's it. And that's what is it being caused by? A distal ulnar nerve lesion. The difference between ulnar claw and Klumpke's palsy is what now? Klumpke's palsy, we discussed in the very beginning, is a injury to the lower part of the brachial plexus, and you're injuring both median and ulnar nerve. So all the hands are going to be impacted. All the hands will be clawed like this. Whereas an ulnar claw, you only have the ulnar nerve affected, which is only going to claw the last two fingers. Is this clear? Is the difference between benediction and hand and ulnar claw clear?
Yes.
Yeah, because they're going to try to trick you. Oh, you're trying to make a fist and all that. Okay. So I added now the ulnar claw and the Benedict's hand into this table. This is the summary table that if you know this, you should be able to answer all the questions. Okay. You're trying to make a fist. Proximal medial lesion, for example, like we talked about arm. So the supracondylar fracture can give you something like this. Okay. Proximal lesion, whereas distal lesion will give you a loss of opposition. Okay. And hand of benediction. So this table should really summarize everything for you. And I think we're done. Oh no, sorry. This is the last question. This is easy. Because she mentioned in the transcript, it's going to come.
Radial
Which
nerve.
artery?
Artery,
Very
yeah.
Yeah.
Deep nerves. The only reason I mentioned it, she said pay attention. Basically, what you need to know, there's two arches that come. Again, I said arteries most of the time you could forget about them, except for when they're important and they make like an anastomosis. So here you have two arches. The radial nerve forms the deep arch, the ulnar nerve forms the superficial branch, and the deep palmar arch, it supplies basically all your fingers. Okay, that's all you need to know. And that is it. We're finally done. I know this was long. I hope this was beneficial though, and you will remember some of the mnemonics and that this was, yeah, that you will, it was a good review for you. So do you guys have any questions for me?
Nope.
No? Okay. Thank you guys very much for focusing. And yeah, if you guys have any questions, you know, my number is in the presentation if you want. So yeah, that's it. And oh yeah, this is the feedback if you guys want to scan it and let us know how I did. Yeah, that's it. Thank you very much.